All right. So how's everybody doing this morning? Good. Okay. So today, welcome to Office Hours. We've got some new faces that I haven't seen before. Winchell, I can't see your face. Alex can't see your face. Logan, how you doing this morning?
I'm doing pretty good. How are you, sir?
I'm well. Tell me a little bit about you. I've never met you, so tell me about you.
Well, I went through paramedic school. Took me about nine. It was a 9 month program, and I got done back in it was like the end of March.
Okay.
Did my capstone, finished my capstone. Attempted the NREMT once. I failed it the first time with like an 833, and then I attempted it the second time. I think I went up to about an 856, and then this last time I took it, I got a 890. So.
Okay.
I'm
So
just
you've
hoping
done it
to,
3 times now?
yep, 3 times.
Okay.
I'm currently working on remedial training, so
Okay. Who are you doing that with, if you don't mind me asking?
it's the paramedic coach
Okay.
one.
And how do you like it, or what's the difference?
I mean, it's so far so good. I mean, he's mostly just it's a lot of PowerPoints. I'm not too big into the PowerPoint learning style,
Okay.
but I like the way you've been doing it. But
Okay.
I'm actually so what I had done, which I shouldn't have done, was I started your program and then went and said, okay, maybe I can go take this thing again, and I went and took it again, and I didn't quite get it. So I'm actually going to lock in this time, and hopefully, it'll go well for me.
Good, good. Well, we've helped lots of people pass at every attempt number from 1 to 6. Um, and here's what I'm going to say: like one of the best things that you could be doing is exactly what you're doing today, where you're showing up and participating. For instance, I think about Billy, who passed his exam last week. I think it was last Wednesday. Billy was actually, and he doesn't mind me sharing his story. He's shared it publicly through our video, but
Mm.
Billy was on his 6th attempt, and in fact, he was somebody who just kind of played around. Really, like he literally messaged me for months, from like February to June or something like that, before he decided to take action. Like, think about it. Think about all those months that he wasted just kind of being out there in the cold, trying to figure things out. Once he made a decision and said, "Hey, I'm going all in on this," from that day, 4 weeks later, he was a paramedic on his 6th attempt. The difference was once he decided to jump in and take action, he really showed up and played full out. I saw Billy probably on every live session, even if he was on shift. There were times where he showed up and then he's like, "Hey, coach, I just got a call." He would leave and then come back if we were still on when he got off the call. But showing up is a big part of it. So kudos to you for doing that today. What I want you to do is continue that. And the reason is I can only help you, or I can best help you. I mean, there are people who pass and I never see them. There are people who pass with just our YouTube information alone. But the people who tend to do the best in the program are the ones that are following the 21-day game plan, and they're showing up, they're playing full out, they're asking questions, that kind of thing. So keep doing that. So we'll have 3 sessions, typically most weeks, Tuesday morning, Wednesday morning, Thursday evening. So attend as many as you can. And right now I want you to continue finishing the remediation course.
Mhm.
The moment you get that done, go ahead and send that certificate off to a national registry and immediately jump into the 21-day game plan. I don't necessarily want you trying to do both at the same time, just because I don't want the information to be confusing. In case we say it differently, likely we will, especially, I mean, nearly every person out there in the world says airway, breathing, circulation. I don't. I teach oxygenation, ventilation, perfusion. I find
Mhm.
that actually works better. Students also say it works better, that kind of thing. So just lock in. So go ahead and knock that out as quickly as you can, and then immediately go into the 21-day game plan. The other thing I want you doing is using the tracker. So inside of the 14-day program, at the very top of the screen, here, in fact, let me just get that pulled up and I'll show you. Have you seen that before?
I've kind of looked over it a little bit, yeah.
Okay. Well, here, just for the benefit of everybody, we'll keep you there for just a moment. Actually, let me just share my screen and we'll share it to everybody. So what I'm going to do is I'm going to go to classroom. We'll go to the 14 days program and daily tracker. Now, for those of you who are testing at the EMT level, you also have a tracker inside the. Let me go there for just a moment. There is also a tracker inside the NREMT Pass Study course at the top, But if you're a paramedic or advanced EMT, you want to use the one inside the program because the two trackers are different. So advanced EMT, paramedic, use the one inside the 14-day program. EMTs use the one inside the NREMT Pass Study course. So let me go back to the 14 days one. Since you're paramedic, daily tracker, when I click to this daily tracker, you do want to use this on the same device every time so that it tracks your progress throughout. And it'll tell you, like, once you put in your name, your exam date, and all of that, it'll start telling you, okay, how many days do you have? Ideally, you want to give yourself a full 21 to 24 days. And it'll literally just tell you what to do every single day, day 1 all the way through day 20. I think it's set up for day 24. But I do want you following this because it's just kind of a visual representation of what you should be doing every single day. And I think it'll help keep you on track. If you get stuck at any point, and this is for anybody, if you get stuck at any point, by all means, let me know. Does that make sense, Logan?
Yeah, absolutely.
Okay. All right. So do you have any questions from me so far? Anything you want to go over? That's kind of what the purpose of today's session is. Sometimes it'll be where I go over a specific topic. For instance, in the recent weeks, we've done acid-base balance. We did one on endocrine emergencies and thyroid situations. We did another one on ACLS and PALS review. We did another one on drug calculations. Actually, we did 2 sessions on that. In fact, you definitely want to watch the most recent one where I went through med math and drug calculations, made it very simple using one formula, one system, one method for every type of drug calculation. So that's what we've done recently in these office hours. But the purpose is for you to just be able to come on, ask whatever questions you have. If there's any content that is not making sense, that's the purpose of this time together. So for anybody, go ahead and get your questions ready. And Logan, we'll just start with you. What questions do you have?
Well, one of the questions that I had that was she keeps coming up on my NREMT that I've been kind of struggling with is I guess so when you're dealing with certain drugs, they have certain drugs that you could overdose on per se,
Of
and
course. Well, you
I
can
guess
just
there's
overdose on
different.
any drug.
Yeah, exactly. So there's different treatments for these drugs. Like I know the common ones like your benzos and all that stuff, but
All
like
right. So hold on. So let's stop. Let's slow it down a little bit, my man. So let's go. You ready?
hmm
All right. So let's go. My man says he wants to talk about. Hold on. Let's see if we can put you in there with me. There you go. You got my iPad?
Yeah.
Okay, let's go. So let's start off with just common overdoses. Okay. So
hmm
probably the most commonly ones that get tested. Okay, it's going to, and by the way, in the Coach Joshua's drawing study guide, if you've signed up at the pro level in the bonus resources, and so in the bonus resources, you get two separate things. I mean, you get several bonuses, but let me show it to you. If I go to classroom, and this is for those of you who have not signed up at the pro level, this is why you want to sign up at the pro level. Because in addition to the NRMT Pass Study course and the 14-day program, you also get the EKG Mastery Challenge, and you get all of the bonus resources. Well, one of those bonus resources, or 2 of them, is the Coach Joshua's 5-star drawing study guide. So in this one, this is like a whole set of my drawings. In this same drawings one, there's a page on overdoses. Also in the comprehensive study guide, there's a section on overdoses. So both of those would be great resources to use, especially to make sure you nail all these overdoses. So let's talk about it. The most commonly ones that get tested are, for instance, an opiate overdose. Okay, let's just go down a list really quickly, and then we'll go through them all. So an opiate overdose. Another one would be like a benzo. Okay, maybe a tricyclic antidepressant overdose, an aspirin overdose, alcohol overdose. Let's say a Tylenol. So that's going to be acetaminophen. Or outside of the US, paracetamol. All right, so these are some common ones. Let's talk about an opiate overdose, okay? How does an opiate work? So here's your cell, and here's your receptor. This is the opiate receptor. Now, it has a particular name, so it's not really called the opiate receptor. What's the actual name for the receptor that opiates bind to?
That's a great
mu
question.
receptor.
Come on, Garrett. Garrett, you're testing at the advanced level, right?
Yes, sir.
But you're doing the 14-day program?
Yes, sir. I'm finished with it.
Check you out, my man. So you've already heard me say this, right? Through the program?
Yes. Yes.
Uh-huh. Little sneaky guy. I thought he just knew this. Okay, but he is exactly right. It is the mu receptor, and that's going to be abbreviated like that. So that's the mu receptor, spell M-U. So what happens with an opiate is the opiate binds to the mu receptor. And then it causes all these symptoms: respiratory depression, somnolence, sleepiness, drowsiness, respiratory failure, all that kind of stuff. Okay. By the way, in an opiate overdose, remember, all problems come to one of three things. They're either oxygenation, ventilation, or perfusion. All problems come to that. In an opiate overdose, what's our primary problem? Is it primarily oxygenation, primarily ventilation, or primarily perfusion? In an opiate overdose, what's the real problem that would kill this patient if we don't act quickly?
Probably be the ventilation issue.
It is. It's a ventilation. Well, let's put that in purple. It's a ventilation problem where their respiratory rate gets knocked out. So now they've got respirations probably less. Oh, sorry. You didn't see what I just did. So hold on. Let's move. Hold on. Let me just add a page here so everything shows in the screen. All right. Hang on just a second. All right, now let's try it. Okay, so what happens is, here's your respiratory rate. So our normal respiratory rate is, for an adult, is 12 to 20 breaths per minute. However, in this situation, respiratory rate drops to below 10. So any number below 10, from 10 to 0 or 0 to 10, all of that is respiratory failure land. By the way, for those of you who've been in the program for a little bit, what's our fix for any ventilation problem, for any reason, whether it's opiate overdose, benzo overdose, neuromuscular disorder, anything that causes respiratory failure, or any ventilation problem for any reason, for 1,000 reasons, what's the fix for a ventilation problem?
Assisting ventilations.
Okay, we're going
Is it
to
a BVM?
We're going to use a BVM. Do we ever use a BVM by itself?
No.
No.
What else do we use with the BVM?
We'll attach O2 to it.
There you go. Check you out. It's always O2 attached to it. We always power it up with O2. And what else do we do? If we're using a BVM, we probably also need to be using what?
Capno.
Well, yes, Capno is more for monitoring, but what else should we be using just because we're using a BVM? That's going to be an OPA or an NPA. Now, this is where 950 medics don't do this. 950 medics who just passed the test, NREMT, they just use a BVM. 3,000 level medics who actually know what they're doing, every time they're using a BVM, they also assist with an adjunct, whether that's an OPA or an NPA, whichever one is not contraindicated. Okay, we never use a BVM by itself. It's always the three stooges so it's going to be a airway adjunct, BVM plus O2. Now, so in an opiate overdose where you have a ventilatory problem, what is the actual problem? Like, what's the issue that causes them to die? Because when they're not breathing, they're not blowing off what?
CO2.
So their CO2 levels are starting to rise. What's our normal CO2?
Isn't it 45? It's like 35 to 45.
All right, who's talking, by the way?
This is
Oh, I thought you were talking to me.
this is Winchell. I don't know how to fix my camera.
Winchell, how you doing, my man?
How you doing, sir?
I'm well. Where are you calling from?
I'm calling from Olive Branch, Mississippi.
Okay, all right, cool. Here, Logan, we'll take you out for just a minute, give you a break off the camera, but okay, so yes, our normal end-tidal CO2 is 35 to 45 millimeters of mercury, and what happens when you are not breathing is you're holding on to too much CO2. CO2 behaves like an acid, and when you hold on to acid, that's going to put you in a state of acidosis. And Garrett, what does acidosis lead to?
Vasodilation.
Man, my man, acidosis leads to vasodilation. So we're going to dilate these arterioles, and then vasodilation ultimately leads to what, Garrett?
Shock.
My man, check you out. So vasodilation leads to shock. So the reason we have to do something for somebody who's not ventilating well for any reason is we have to ventilate them to prevent them from going into shock, okay? Because ultimately what's going to kill them is they're going to go into shock, and then their shock, once they progress. So let's go over that again. When you have too much CO2 behaves like an acid. That puts them in a state of acidosis. Acidosis leads to vasodilation and shock. Here's what happens in shock. There's one equation to know. It's our blood pressure equals heart rate times stroke volume times systemic vascular resistance. Notice what we're doing here. We were talking about opiate overdose, and I'm already in a shock. It's because everything is related. You need to know how everything is connected. That helps you think through situations on a test. It also helps you think through situations in real life. So let's go back to the situation of shock. How does this patient with an opiate overdose die? What happens is they end up with respiratory depression. So in this respiratory depression, so remember, this is kind of the order of things. We start off with ischemia. Ischemia progresses to hypoxia. Hypoxia progresses to respiratory distress. Respiratory distress progresses to respiratory failure. Respiratory failure progresses to respiratory arrest, and respiratory arrest progresses to cardiac arrest. Okay? Now, but how does it happen? That's what happens. How does it happen? So when I dilate these blood vessels, I dilate blood vessels everywhere, including the brain. So when I dilate blood vessels in the brain, now I have increased intracranial pressure in the brain. That increased intracranial pressure in the brain now starts pushing on the brain stem. In the brain stem is where the respiratory center is located. And when you knock out your respiratory center, now you can't breathe. That's how they go into respiratory arrest. Okay? And now when they go into respiratory arrest, how do they make this jump into cardiac arrest? Well, as they further go into shock, what happens is when we dilate these blood vessels, the systemic vascular resistance goes down. When the systemic vascular resistance goes down, the blood pressure also goes down. When the blood pressure continues to go down, the mean arterial pressure drops below 65 millimeters of mercury. That pressure goes down, and now eventually we don't have enough pressure to send blood to the brain. Okay? And we also don't have enough pressure to flow blood through the heart. And so when we don't have enough pressure to send blood out of the heart or back to the heart doesn't get any blood. And when the heart doesn't get any blood, nothing comes in, nothing comes out. That equals cardiac arrest. Does that make sense? So that was a lot of information. Let's see who could hit me with all that again. Because I never want you to just know what something is. I never want you to just recognize respiratory failure. I want you to understand, how does a patient go through all these steps? There's something happening behind the scenes that makes all of this happen. Christian, I'm looking at you. I want you to hit me with all that one good time. Christian, so your job is to tell me how in an opiate overdose do they ultimately die if we don't do something. So let's start us there. Let's start with an opiate overdose.
Okay, so when somebody has an opiate overdose, the opiate connects to the mu receptor.
Ooh, good.
That mu receptor is then going to lead, all of that is going to lead to ischemia.
More specifically, in this case, we're starting at the hypoxia stage.
Or hypoxia, excuse me. Mm-hmm. That's going to build up CO2. CO2 is going to lead to acidosis.
Okay.
Acidosis is then going to lead to dilation.
What kind of dilation? Vasodilation. There you go. Vasodilation. Okay. Keep going.
And then from vasodilation is going to lead to shock.
Okay. And vasodilation is going to lead to shock. And when you're in shock from all this vasodilation, what does it do to the resistance? When you make the pipes bigger,
it lowers the vascular resistance, which in turn lowers the
systemic
blood
vascular
pressure.
resistance goes way down. And when anything on this side goes down, what also happens to the blood pressure side?
Goes down.
It goes down. And when the blood pressure keeps going down, what happens to the mean arterial pressure?
That decreases so much.
It goes down.
There's no blood.
When that goes down, you don't have enough pressure to pump blood where it needs to go. What's the most important place that blood needs to go?
Brain.
The brain, because what's the brain's two favorite snacks?
Oxygen and glucose.
Oxygen and glucose. So when there's no blood flowing, there's no oxygen and glucose flowing to the brain. Okay. Now the brain starts to, well, part of it is we dilate some of the blood vessels in the brain. That leads to increased intracranial pressure. That starts, so here, let's draw that out.
I was going to ask you that question. I was confused on how there's more pressure in the brain, but yet less blood to the brain. How does that make sense?
It's because so one of the things that the body does to compensate is because it has to keep the brain alive. So inside or the blood vessels going to the brain, those also dilate initially. Okay. But now if I dilate these blood vessels, now I have more blood or more swelling, more volume going to the brain. Well, because there's a skull around the brain, when I keep putting more volume going to the brain and then more pressure, eventually that volume starts to go into the brain stem. Okay. And then here in the brain stem, here's our respiratory center. This part that I'm highlighting, that's the medulla oblongata of the brain stem. That's where our breathing center is. When I keep putting more pressure or more volume that knocks out the brain stem, this now in turn knocks out my respirations. This is how an opiate causes respiratory depression. When I have enough respiratory depression, it's going to lead to respiratory failure, and then eventually it leads to respiratory arrest. Okay. And then because elsewhere in the body, once you don't have enough blood flow, we now don't have enough blood flowing into or out of the heart. That's going to ultimately shift them into cardiac arrest. This is how a patient ends up dying from an opiate overdose. Okay. So in an opiate overdose, our situation is we've got a ventilation problem, and our fix for that is going to be a BVM first. This is why Narcan is not the first fix for an opiate overdose. Narcan, what does Narcan do? First of all, how does Narcan work? Narcan.
Oh, sorry.
Keep going. So here's Narcan. Well, let's see. Am I on the screen? Okay, this green thing I'm drawing right now. This is going to be our Narcan. Let's call it naloxone. How does it work? Narcan says, hey, okay, keep going.
I thought you were asking me. My bad.
I am.
It binds to the mu receptor so that it blocks the opiate from connecting.
So here's our Narcan or our naloxone. It binds to that same mu receptor. What it does is it prevents more opiate from binding because the seat is already taken up. They both compete for the same spot. So they're what are called competitive. It's what's called a competitive inhibitor. You have two types of inhibitors, competitive and non-competitive. A non-competitive inhibitor attaches to another site, what's called the allosteric site. In this case, this is a competitive inhibitor. It competes for the same site. Okay, so Narcan, all it does is it prevents more narcotic from binding to make the situation worse. But the Narcan by itself does not blow off the CO2 for them. Remember, when they're not breathing, they're holding on to too much CO2. CO2 behaves like an acid, puts them into acidosis, leads them into shock. We got to do something to get rid of the CO2. That's where the BVM comes from. That's why it's the first thing we do. So narcotic, first thing we do is BVM. The next thing we do is naloxone. Okay. What's our dosage going to be for naloxone?
I have a quick question, Joshua.
Hold on, hang on. What's the dosage for naloxone? All right, that's going to be 0.4 to 2 milligrams. It can be given lots of different ways. How can it be given?
IV intranasally?
It could be given IV. We typically don't do it IV. Primarily, we want to give it intranasally just because it's very in the nasal mucosa in the nose. In the nasal mucosa in the nose, it's very quickly, it has quick uptake, rapid absorption because there's a lot of blood supply there, so it immediately gets into the bloodstream. We can also do this through, we could even do it IM. We could do it IO. I mean, we can give it lots of ways, but intranasal would be preferable. Okay, Christian, what's your question?
So the times that I've given Narcan before, for somebody like with fentanyl overdose or something like that, a lot of the times you'll give them the dose, they'll pop back up or whatever and
Yeah.
be awake, and then they'll pass back out again and it hits them again. Is that
Okay.
because Narcan has like a less half-life than an opiate, or how does it work where it doesn't stay binded until they're okay?
Yes. So yes, half-life is essentially what's happening. I don't know the exact half-life of Narcan, but what's happening is so let's go back to the drawing. So what's happening is when this naloxone naloxone is green. So when the naloxone or Narcan binds to the mu receptor, it prevents more from attaching. But the thing is, okay, so yes, you may see some effect, some positive effect where the patient like comes back to life. But what you don't know is, Narcan's in purple, you don't know how much more Narcan is nearby, already in the bloodstream. So there are other, because you don't just have one receptor, you have thousands of receptors. So you can still have other Narcan attaching to other mu receptor sites. Does that make sense? I mean,
Yeah.
I'm sorry, other narcotic. You can still have other narcotic attaching to other places. So it helps in some of the places, but it doesn't necessarily address all the receptors at the same time. You've got receptors all over the body. Okay.
So how come we don't give them more than just 0.4 to 2 milligrams if we know we're going to?
We may have to repeat it.
Okay. Yeah.
Yeah, we absolutely may have to repeat it. It's just we start them off with, you want to start them off with the lowest dose possible, because what can happen is you can shift them from an opiate overdose, and you can detach so much narcotics so quickly that you now shift them from overdose into now opiate withdrawal. And so now you've got like the opposite effect where they're violent and all of that. They're vomiting and those kind of things. So we want to give them just enough to have the desired effect, but not any more than that.
Copy.
All right. That makes sense?
Yes, sir.
Okay. So first treatment for an opiate overdose is?
BVM.
BVM, because it's a ventilation problem. The narcotic is just the medication that we're going to use to kind of assist us. Okay, let's go to benzo overdose. So Logan asked for overdoses. Let's go to benzo. What's our drug of choice for a benzo overdose?
Flumazenil.
Flumazenil, also known as Ramazicon. Flumazenil, also known as Ramazicon. Okay, let's say we have a tricyclic antidepressant overdose. What's our drug of choice there? Hey, Winchell, how you doing, my man?
Sure.
All right, unmute for me. Okay, there you go. I got you now.
Yeah.
And so what's a tricyclic antidepressant? Okay, it behaves like an acid.
Okay.
What's our fix for acid overdoses?
O2.
No, not primarily.
Bicarb.
Bicarb.
Okay,
Yeah.
so the very first thing for an acid overdose, when they have too much acid, we're going to neutralize the acid, and the first thing we're going to use to neutralize the acid is fluids. Okay, now what fluid would be ideal in this situation? So of our isotonic crystalloids, one of those can make acidosis worse. If they already have too much acid, I don't want to give them something else that's going to turn into more acid. What is the one that causes more acidosis? So let's.
Is it lactated ringers?
That you want to give or don't want to give?
Don't want to give.
No.
I think you want to,
Okay.
yeah, you want to give LR.
All right, so check this out. So you know how we have isotonic crystalloids? We have hypotonic, and then we have hypertonic. Okay, isotonic. So the examples there, that's going to be normal saline, and that's going to be lactated ringers. Those are both isotonic crystalloids.
Okay.
The problem with saline is saline contains, so it's 0.9% sodium chloride. Na is sodium, Cl is chloride. Those two together make salt. Saline contains sodium and chloride. The problem is, here, let's put the sodium part in black. The problem is the chloride. The chloride part leads to acidosis. And we already said that acidosis leads to vasodilation, and vasodilation leads to shock. This is why if you have a patient who's already in some type of shock, let's say you have a trauma patient who's in hypovolemic or hemorrhagic shock, normal saline could worsen their situation because it's going to further aggravate or what's the word I'm trying to think of? Enhance or whatever the likelihood of shock. Okay. On the other hand, Ringer's is made up of sodium, potassium, calcium, and lactate. Okay. So if you have, so the times where you want to use Ringer's are going to be major trauma, burns, sepsis. Okay. So major trauma, burns, sepsis, Ringer's is better than saline because saline has chloride. Chloride leads to acidosis. Acidosis leads to vasodilation and shock. Okay. So if you have any kind of patient in any kind of shocky situation, saline is probably not the best choice. If you have Ringer's, use Ringer's. So in this situation, let's go back to where we were. In this situation where you have a tricyclic antidepressant overdose that behaves like an acid, the Ringer's actually may be preferable. However, in the short time that you're going to be with them, if saline is all you have, that's okay. It's better than nothing. So what we're going to do is we're going to give them some water to neutralize all this acid. So fluids first, and then the next thing is going to be bicarb. So fluids and then bicarb. Okay. Let's say we have an aspirin overdose. Same kind of thing. Aspirin is acetylsalicylic acid. So it's too much acid. How do we fix acid problems? Primarily, we're going to go fluids and bicarb. So that same treatment could apply there. So number one, for an aspirin overdose, we're going to give fluids, and then we're going to give bicarb. Now, I'm not saying these are the first things you do, but I'm saying in terms of like medication treatments, these are the first things you do. It still comes down to, do we have an oxygenation, ventilation, or perfusion problem? And we have to do whatever is going to fix that. In this case, though, let's talk about an aspirin overdose. Aspirin overdose, not only the reason it's so problematic is it causes some big time acid-base disturbances. So let's talk about an aspirin overdose. So we have an aspirin overdose. Initially, in the early phase, it causes one acid-base problem. But then later, it causes another acid-base problem. What's that? Anybody know? Alex, you know this yet?
No, I don't.
No problem. Okay. So, Cody, are you seeing my screen now? Is everybody else seeing my screen?
I see it.
Okay. All right, Cody, it may be just your device. What you can do is exit out of the Zoom room, come back into the Zoom room, and see if that fixes your screen issue. All right, in an aspirin overdose, the very first thing that happens when it comes to the acid-base disturbance is early on, it leads to respiratory alkalosis. Okay? In respiratory alkalosis, how's your pH going to be? If it's alkalosis, pH is going to be what?
High.
All right, so pH is going to be high, so that's going to be greater than 7.4. Okay, now because it's a respiratory, remember in respiratory situations, pH and CO2 go in opposite directions. So if pH is high, then that means the CO2 goes down. And when I say going down, that means, so remember on our acid-base thing, and I did a whole video on this, we're going to put 45 on the left, 35 on the right. When it goes down, it means that it's less than 35. Okay. So that's our CO2. Aspirin overdose in the early phase causes respiratory alkalosis. And in the late phase, it causes metabolic acidosis. Okay. Speaking of metabolic acidosis, what's our mnemonic that we're going to use, our acronym, to figure out most likely causes of metabolic acidosis?
Is it Rome?
No, Rome is what we're going to use to figure out respiratory opposite, metabolic equal. That just helps us figure out pH compared to bicarb or pH compared to CO2, which direction they go. Do they go in the same direction or not? That's Rome. But for metabolic acidosis specifically, what's our acronym there? All right, so this is going to be mud piles. Some people use gold mark. I use mud piles. So what are our causes of metabolic acidosis? Most common causes. M is methanol. So that's going to be alcohol. So methanol. U, tell me what's the U? All right, so all of you, so most of you are paramedic students, and you need to immediately be able to know these answers. So if you're in our program, you want to make sure that you're doing those rapid drills. If you're not in the program, you need to get in the program, because this is why I say you don't want to be a 950 medic. 950 medics just memorize stuff they heard somebody say. You need to be a 3000 level medic who really knows what you're doing. So, because if you have a patient who has suspected metabolic acidosis, you got to figure out why so that you know how to treat it. Now, the U, that stands for uremia. So that's probably a kidney problem. The D, it could be diarrhea. It could be several things that start with D. The P, what's the P? Anybody know? Okay, this is going to be propylene glycol. Propylene glycol is in lots of things. It's in lots of medications. It's in blood transfusions. Lots of things have it like as an additive. So lots of medications could have this or could lead to this because they have this ingredient or this waste product in it. What's the I? The I is going to be an iron overdose. Isoniazid. Isoniazid is a drug that's used for tuberculosis. The L, this is going to be lactic acidosis. So this is primarily going to be our septic patient. The E is ethylene glycol. Ethylene glycol is a big ingredient in antifreeze. So antifreeze or de-icing solutions for windshield, things like that. And then the S is salicylate. So that's going to be like your aspirin, okay? Salicylate toxicity. Okay, you want to know this. You want to know your causes of metabolic acidosis. So let's kind of recap where we were. We were talking about aspirin. Aspirin is acetylsalicylic acid. So when you overdose on it, it can eventually, this is how it's going to eventually put you in acidosis. But it doesn't start there. It actually, one of the first acid-base disturbances you'll have is respiratory alkalosis. But then later, as you keep hanging on to it, then it's going to progress you into metabolic acidosis. And what have we noticed so far? Every time I've said acidosis, I've also said any kind of acidosis leads to what and what? Just unmute. Acidosis leads to anybody?
Vasodilation.
Vasodilation, and vasodilation leads to shock. Okay, so this is how anything can lead to cardiac arrest. Because if I have shock, as we went through earlier, any kind of shock for any reason, we drop the systemic vascular resistance, or we drop the blood pressure, we drop the mean arterial pressure. Now we don't have enough pressure to send blood to the brain or to the heart. Okay, and that combination proves to be deadly, because that is exactly what's going to put them in the cardiac arrest. All right, so let's go back over this. So far, we said opiate overdose. We're going to use Narcan or naloxone. How does naloxone work again?
It's a competitor for the receptor.
Which receptor?
The mu receptor.
Okay. Yes. Naloxone or Narcan is going to bind right here to the mu receptor, spelled M-U. This is the Greek symbol mu. Okay. But is Narcan the first thing we do?
No.
No, what's the first thing we do? Because it's a ventilation problem.
It's our three stooges. It's going to be our
Three students,
BVM,
we got a BVM plus O2 plus
OPA.
airway adjunct. Nice.
Yeah.
Benzo overdose. What's our treatment of choice for that, if you have it?
Flumanazole.
No.
Flumazenil, also known as Remazicon. For a tricyclic antidepressant overdose, what's our treatment of choice?
Sodium bicarb.
Do we start with bicarb?
No.
Do we start with? What's the simplest thing we
Fluids.
can start with? We go simple before complex.
Lactating
Easy before-
bringers.
So we're going to go with fluids. The preferable fluid in this situation would probably be ringers. We're going to go fluids and then bicarb. Okay. Same for an aspirin overdose. We're going to go fluids and then bicarb. Okay. Now let's say we have an alcohol overdose. What would we give them here?
Is it thiamine?
Okay. So thiamine, what is thiamine?
Is it a vitamin?
It
Vitamin
is
B?
a vitamin. Which vitamin is it?
Vitamin B? B1?
Which one? Say it again.
B1?
Nice. Check you out. It is vitamin B1 since you want to show off. Let's go. Let's go vitamins. You notice I can just sit here with no notes and just go from anything to anything. I'm not doing this to impress you. This is exactly where I want you to be. Man, guys, check this out. Don't tell the ladies. This is the first time ever we've had an all guy crew. I like this. This has never happened ever. All right, so let's hit up some vitamins real quick. All right, when it comes to vitamins, now I'm going to come back to the overdoses, but let's go over vitamins real quick. I don't actually think I've ever done this in any situation, in any EMS situation. All right, so vitamins are broken down into water-soluble vitamins and fat-soluble vitamins. Okay, this is a good thing to know, though, just in general. These are your options. It either breaks down through water or it breaks down through fat. All right, Winchell, we'll take you out for just a moment. Give you a break here. All right, so this is for everything. All medicines work the same way. They either dissolve in water or they dissolve in fat. Let me tell you why you care. Why do you care if it's water soluble or fat soluble? Let me show you. If it's a water soluble, so let's put water in blue. That makes more sense. If it's water soluble, the primary organ that's going to help to metabolize it is the kidneys. There's a lot of water. There's a lot of blood in the kidney flowing through the kidneys. That's the job of the kidneys, to filter blood. So anytime you have a water soluble thing, if it's likely to mess up an organ, it's likely to mess up your kidneys. Okay. Now, how would somebody detect that somebody has some kind of kidney problem? We're probably going to see changes in the kidney labs. What are our primary kidney labs that we use? That's going to be our BUN and creatinine. Now, and by the way, this is BUN and not BUN. It's BUN. That stands for blood urea nitrogen. So anytime somebody has some kind of kidney problem, they're probably going to have an increase in their BUN and an increase in their creatinine labs. Okay. Now, obviously, you would need to know what the labs are to know there's an increase. I'm not going to go into labs today because that's a whole other topic. But what you want to know, and check this out. If you have something that is metabolized by the kidney, it's water soluble, and it's also typically going to be a very small molecule. Okay. I'm sorry. No. It's going to be a large molecule. A large molecule. Okay. And it's transported through water. The issue with a large molecule, or kind of the benefit of it, is it has a hard time getting into places because the molecule's size is so big, it has a hard time like sneaking in little cracks. Okay. So how can that be a benefit? Well, that means that it has, when it's water soluble, if the molecule is big, it has a hard time sneaking into places, so it's less likely to travel everywhere. Okay, so we call that volume distribution. Volume distribution, everybody just stay with me. I'll make sense of this. Volume distribution is how much gets distributed everywhere. When you have big situations, big molecules that are big sizes, it's hard for them to go everywhere. So they kind of stay in one place. So for instance, like in the kidneys, they kind of stay in the kidneys. And this is why they cause kidney problems or kidney failure and not so much other situations, because it kind of stays right there. It can't really get out. Okay. So it has what's called a low volume distribution. Water soluble things are metabolized by the kidneys. If we have kidney problems, it's going to affect our kidney lab. So we're going to have an increase in our BUN, increase in our creatinine. Now, the good thing though is when you have a water soluble situation, also these things typically behave like an acid. This is why when you have this is why the treatment for most acid type overdoses is some kind of water. Does that make sense?
Yeah.
Okay. Now, see how I was talking about vitamins, but we're going to tie this into, we just talked about a tricyclic antidepressant overdose, which behaves like an acid. The reason, since it behaves like an acid, one of the things that we can do is we give them water to neutralize the acid. This is why fluids is first, and then later we can also give bicarb to neutralize the acid. Okay. Now let's talk about water soluble vitamins. The water soluble vitamins are going to be your B complex vitamins and your vitamin C. So B and C. So BC, like before Christ, or like a BC powder, those are your water soluble vitamins. Now, all right, hold on. Let's make sure we can see this. When it comes to the B complex vitamins, we have several ones. We have vitamin B1, B2, B3, B5, B6, B7, B9, B12. Okay, vitamin B1, that's the one that's known as thiamine. Okay, what happens if you have a thiamine deficiency? Who has this? Well, alcoholics. So when Chell said, okay, in an alcohol overdose, we may give thiamine. That's mainly a, we could give thiamine, but it's just a vitamin at the end of the day. So it's not going to make that much of a difference. The main thing, let me come back to that. The main thing that we're going to give in a alcohol overdose is we actually give them methanol a little. But then we also need to give them, because all this alcohol or methanol, remember how I said that methanol behaves like an acid and causes metabolic acidosis? And what did I just say is the first thing that we do for any kind of these acidosis situations to neutralize the acid?
Fluids.
Aha. So in an alcohol overdose, this is why all of them end up getting IV fluids. Okay, to help kind of neutralize some of the acid. There again, we may also have to give bicarb later, but we may, in addition to that, have to give them a little methanol. Now let's go back over the vitamins real quick. You don't have to know all of this part, but if you've heard these words, I want you to just kind of make some sense of it. Anybody know what vitamin B2 is called? Okay, let's go back to B1. Thiamine. The reason you need it is if you don't have it, two things that it can cause. One of them is beriberi. Okay, there are two flavors of this. We call it dry or wet beriberi. The two flavors of this, one of them causes neurological disorders. One of them causes heart failure. Okay, so if you don't have thiamine in your diet or in supplements, it can lead to a situation called beriberi. Neurological beriberi is where you're having brain problems, or it can cause heart failure. What's vitamin B2? That's going to be riboflavin. That's found in milk and lots of other animal sources. If you don't have it, it causes things like angular chelosis, where you get these sores on the corners of your mouth, stuff like that. Vitamin B3, that's niacin. This is needed for a whole lot of chemical reactions in the body, but niacin. If you don't have enough niacin, it causes something called Hartnupp's disease. It also causes diarrhea, dementia, diarrhea, dementia. It can lead to death. Okay. All right. What's vitamin B5? Vitamin B5 is, anybody know?
Mm-mm.
All right. Vitamin B5 is pantothenic acid. It's also needed for a lot. It's a main ingredient for a lot of chemical reactions that take place in the body. So that's pantothenic acid. Vitamin B6, that's pyridoxine. And you can just look this up. You can just Google or ChatGPT or Gemini or whatever your source is. You can just look up, okay, give me a list of the vitamins. Vitamin B6 is needed for a lot of stuff. When you don't have enough of it, it causes things like peripheral neuropathy. So it causes numbness and tingling in your fingers and toes and stuff like that. So if you have any patient with some kind of neuropathy, one of the levels you want to have checked is their vitamin B6. Now, why am I telling you this stuff? Is this stuff on National Registry? No, but sometimes you may be the most educated medical person in some kind of situation and nobody else knows this. So the more you know, sometimes it tells you what to do, sometimes it tells you what not to do, but it also allows you to better educate your patients, your family members, yourself. Okay. So pyridoxine, vitamin B6, it's going to be used for preventing things like peripheral neuropathy. So nerves need vitamin B6 in order to do their job. Vitamin B7, that is, say it again. Oh, okay. Vitamin B7, that's biotin. Biotin is needed for muscle building. It's also needed to make hair, skin, and nails. So a lot of women who take some kind of vitamin B7, it's to help their nails and their hair and their skin look good. Their nails and hair grow and their skin look good. Vitamin B9 is folate. Okay. Vitamin B9 is it's needed to make DNA. This is why pregnant women need to take prenatal vitamins, because one of the things in prenatal vitamins is folate. If, let's say, a pregnant mom doesn't know she's pregnant or she's not taking her prenatal vitamins, she's not getting folate, it's hard for the baby to develop, especially their brain. So they can now have like neural tube defects, like spina bifida occulta, things like that, where they literally have like their brain doesn't even develop, or they have like either no brain or a small brain, or they have problems with their spinal cord, those neural tube defects. So folate is needed like for life. And this is why pregnant women have to take a prenatal vitamin, because it contains vitamin B9. And then vitamin B12, that's cyanocobalamin. Okay. This is also needed for nerves. So whenever somebody has neuropathy, we want to check their vitamin B6 level, their B12, and also their B9 level. So this is a case for why you want to make sure that your diet is good, so that you have all the essential vitamins that your body needs. Your body can make some things, but some things you have to have it synthesized, or you have to get it through food. This is a case for why you want to take vitamins, or at least why preferably you want to get it through your food or through your diet. But if your diet is just trash, like a lot of people in EMS, you definitely want to supplement your diet with some type of supplement that definitely contains these B complex water soluble vitamins. Okay. The other water soluble vitamin is vitamin C. And then the fat soluble vitamins are going to be A, D, E, and K. Let me tell you about these really quickly. Because they're dissolved in fat, where is a place where it's very fatty in your body? That's going to be your liver. Okay, your liver. So when somebody has an overdose on any kind of fat soluble substance, whether it's vitamins or anything that's dissolved primarily in fat, it really destroys your liver. So how would you recognize it that somebody has some kind of liver problem? We're going to see an increase in the liver labs. That's going to be an increase in our ALT, alanine transaminase. That's going to be an increase in our AST, our aspartate transaminase, and our GGT. So when you look at labs sometimes and you see in your lab report, okay, ALT, AST, GGT, these are liver enzymes. And when they have an increase in these, it's probably some kind of liver failure from too much fat soluble substances. Now, on the other hand, remember how with water things, they're dissolved in the kidney. They are large molecules, so they don't really go all over the body. They kind of stay in one place. On the other hand, these fat soluble are very small molecules. They can travel everywhere. They can sneak in all little cracks and crevices throughout the body. So they can go all over the body. They have an increased volume distribution. And what else is so crazy about this? Because they can go everywhere, they can very easily cross over the cell membrane. Well, if they can cross over the cell membrane in the brain, they can now, so in the brain, they can cause things like drowsiness, somnolence, lethargy, slow to response, unresponsiveness, things like that. Okay, let's say if I cross over membranes in the muscle, ooh, now I'm going to have things like muscle cramps, rhabdomyolysis, stuff like that. Okay, let's say I cross over membranes in the heart. Oh, now it can cause things like carditis, excuse me, pericarditis. Okay, let's say I cross over the membranes in the liver. Now it can lead to things like hepatitis. Okay, let's say I cross over membranes in the pancreas. Now I can have things like pancreatitis. Okay, now what can I do with this information? What can I do with this information now that I know this? Everything in the human body, guys, this is exciting. Is anybody else learning or just me? Here, everybody come off mute for me. All right, have I lost anybody?
No.
No.
Okay, how are you feeling about this so far?
Are we on this ride with you?
Yeah.
Come on, check this out.
Joshua,
You're not getting this in most paramedic schools. Okay, check this out. Every substance in the whole human body, it either has one of two ways it has to work. It has to work like an acid or it has to work like a base. Okay, this is how I can take any medication in the whole wide world. I don't have to know the name of it. I don't have to understand how it works. All I have to do is ask a doctor or a pharmacist. Hey doc, I got one question for you. How often do you give this drug? Oh, if they tell me, oh, this drug has to be given every 4 hours, every 6 hours, every 8 hours. Bingo. That's all I need, doc. I don't need to know the name of the drug. Don't even worry about telling me. You said it has to be given every 4 hours. That means it's a water-soluble drug. It's going to be metabolized by the kidneys. It's going to have low volume distribution. Because it's metabolized by the kidneys, because it's metabolized by the kidneys, when the kidneys get destroyed, we're going to see an elevated kidney enzyme. So we're going to see an increase in the BUN, increase in the creatinine. It's going to behave like an acid. Because I got too much of it, the first thing I'm going to do is I'm going to give them fluids. Next thing I'm going to do is I'm going to give them bicarb. And it's like, how did you know all that? Well, I just needed one question. How often is the drug given? Now, let's say you give me another drug and you say, hey, this drug is given once a day. Oh, once a day means that it lasts a long time. Aha, that means it's going to, instead of behaving like an acid, oh yeah, it's going to behave like a base. Okay? It's going to be a small drug. It's going to be a small molecule. It can travel everywhere. It has a high volume distribution. Because it can travel everywhere, it's likely to knock out the liver. We're going to see an increase in the liver enzymes, increase in the ALT, the AST, the GGT. It can knock out the pancreas. So I can see an elevated pancreatic enzymes, our amylase, our lipase, things like that. It can cause pancreatitis. It can cause hepatitis. It can cause carditis. It can cause myositis, rhabdomyolysis. It can cause, it can wipe out the brain and cross the blood-brain barrier. Now they're going to be sleepy. They're going to be tired. They're going to be fatigued. All I needed to know is how often is the drug given. You see the importance of why you want to know more than just what's in your textbook? how do you guys feel about this?
I feel informed.
Yeah.
Okay. All right. So what we covered so far with vitamins, we said vitamins are either, but this is not just vitamins. This is every substance in the whole body. It either behaves like a water soluble something or a fat soluble something. In the case of vitamins, the water soluble vitamins are going to be our B's and C's. And then we have B1, 2, 3, 5, 6, 7, 9, and 12. Okay. Those are our B complex vitamins. You can just look up the names if you need to. Our fat soluble vitamins are vitamins A, D, E, and K. We want enough of these, but we don't want too much of these, because at least when we have too much of the water soluble vitamins, we just pee off the rest. When we have too much of the fat soluble vitamins, we don't pee it off. It hangs in our body for years, and it causes all these other problems that we mentioned. Okay. All right. Now we went into that and we made a connection between water soluble things and like aspirin overdose and alcohol overdose.
Joshua, I have a question before we move
Yes.
on, if that's okay.
Huh?
The B12,
Okay.
the name of that one.
Cyanocobalamin.
Yep.
What about
Is
it?
that why, like, I mean, I see a lot now of patients who use a lot of nitrous oxide.
Okay.
And I really kind of did a deep dive, which it all connected now, because when you said that a lack of that name, the
Cyanocobalamin.
Mhm.
What about it?
Well, people with that do a lot of like nitrous oxide, from what I think is they lose that myelin sheath around the neuron,
Okay.
which slows down the conduction. And I remember you just saying that somebody with a low B12, it affects their neural system.
Absolutely.
So kind of all put the pieces together for me then, because if they're low in that B12, then that means they're eating away at that myelin sheath, which then is affecting their neuro system.
Yes.
Right.
Absolutely. Now, it can take a while for B12 is one of those things that actually stays in your body for years. It primarily comes from animal protein, but who's most likely to have a B12 deficiency? That's going to be a vegan who totally 100% consumes plant-based sources and no animal protein. And so they will typically have to supplement. But because B12, it's involved with intrinsic factor, it's involved in digesting certain bacteria, that kind of thing. But it stays in your body for years. So it actually takes years to develop a B12 deficiency, but there are things that you can do to speed it up, to get rid of more of it faster. But vegans are definitely somebody who's likely to have a B12 deficiency. Here, let's just put that. So vegans, especially vegans, are likely to have a really low B12. Okay. All right. Any questions about any of that? Like, I wasn't even planning on going into any of that, but I'm ready at all times. So let's go back to this overdoses. We were talking about a lot of different kinds of overdoses, Logan. A Tylenol overdose, also acetaminophen or paracetamol. What's our antidote for that? What's our big antidote for a Tylenol overdose? How does Tylenol work? Okay, so Tylenol, what is the risk of Tylenol? All right, here's what you want to know. Tylenol causes what's called fulminant hepatitis. That's just a fancy way of saying your liver gets destroyed today. Like you could have had a normal liver yesterday, but you took a bottle of Tylenol today and your liver is wiped out today. Okay? We don't see that kind of rapid destruction with most things, but this is why Tylenol is so deadly. This is why Tylenol is one of the most commonly used drugs for suicide attempts. You get called for a female, or it could be anybody, but the stereotypical situation is a young female who takes a bottle of Tylenol. Now she's unresponsive. What it does is it immediately, like in a matter of hours, like 3-4 hours, totally destroys the liver. What's the job of the liver? The liver's job is to detoxify the body. When you give it all that Tylenol, all that acetaminophen at once, you overwhelm the liver, you totally destroy the cells, the hepatocytes of the liver. Now the liver can't detoxify the body or the blood, so they accumulate a whole bunch of toxins very quickly. Those toxins behave like an acid. Wait a minute, this is starting to sound familiar. And that then puts them in a state of acidosis. Acidosis puts them in a state of vasodilation. Vasodilation leads to shock. Shock leads to cardiac arrest. This is what kills the patient in a Tylenol overdose. You notice these same patterns keep coming up over and over and over again? Like no matter what I'm talking about, we somehow get to the same place. Okay. So what's our antidote for Tylenol? Anybody got it? All right. This is going to be Mucomyst, or also known as N-acetylcysteine. Okay. N-acetylcysteine, also formerly known as Mucomyst. Okay. So when in doubt, though, you're going to call poison control. By the way, what's the number for poison control? All right, everybody take out your phone right now. All right, everybody ready? Take out your phone. You guys ready?
Yep.
Okay, number for poison control is 1-800-222-1222. 1-800-222-1222. 1-800-222-1222. 1-800-222-1222. All right, you want to put this number in your phone. Make sure your family knows this. Poison control works like 911. It works all over the country. There are poison control centers located throughout the U.S. where they're like pharmacists, epidemiologists, pharmacologists who are there in the center. They have a database of millions of substances. They have information at their fingertips. So when in doubt, if you ever have adult, child, anybody who's ingested some kind of substance, or they've gotten exposed to some kind of substance through one of the ways that things enter the body, poison control is your best friend. Sometimes even over like med control, because even when you call med control, they're still going to have to turn around and call poison control. So you're not going to call 911 because you are 911, but your first call should be poison control. 1-800-222-1222. And you want to be as descriptive as possible. Don't necessarily take the substance with you to the hospital, especially depending on what it is. It's like if it's a cleaning supply or something like that, leave that at home, but just take a picture with your phone. Try to take a picture of the front and the back. What you're really trying to get is the label. Okay. And you want to be as descriptive as possible, telling that pharmacologist or that epidemiologist, whoever you're talking to, whoever the scientist is that you're talking to, you want to tell them all the symptoms that the patient is having, any kind of containers nearby, what's the environment looking like, stuff like that. Any questions on that? So that's going to be yeah, go for it.
I have a question. So because this isn't a medication that we would have
what
out in the field, the Mucomyst.
Okay, the N-acetylcysteine. Uh-huh.
Yep.
So what it does mean is that it may affect your destination hospital. You want to make sure that you're going to preferably like a level 1 type center. I mean, most hospitals have this, but some of these rural hospitals, these small town hospitals, they don't have all of this stuff in the formulary. They don't have access to all of this from their pharmacy. So it may mean that you should drive 10 more minutes, 20 more minutes, 30 more minutes to a higher level hospital that's more capable. Because you got to think, any of these overdoses, they're likely going to need like ICU level care. So you definitely want to make sure that you're immediately going to an ICU level facility. What you don't want to do is just take them to the closest hospital just because it's close, or you don't want to go out of service to go to the next hospital because you're trying to get back to your lunch. Because what's going to happen is now once they get to that smaller hospital, the doctor has to evaluate them. Then they have to arrange a consult, call another doctor, get an accepting provider at another hospital, arrange for transport. And now it's going to take 3-4 hours, sometimes minimum. Sometimes it's all day before that patient now gets transported to appropriate care. it would have been better for you to just, if there was nothing that, just because a hospital is close doesn't mean that's where you go, unless it is something that's like time sensitive, like an airway situation. But otherwise, you're a paramedic who's highly trained. You just want to take care of the patient. If it means that I'm stuck with a patient for 30 minutes instead of 15, so be it. I'm trained. I know how to take care of patients. It's either an oxygenation, ventilation, or prifusion problem. If it's an oxygenation problem, I fix something with the airway or I give them oxygen. If it's a ventilation problem, I'm primarily going to use a BVM plus O2 plus an airway adjunct. If it's a perfusion problem, I'm going to do something based on the perfusion equation. The perfusion equation is, remember, blood pressure is heart rate times stroke volume times systemic vascular resistance. If it's a perfusion problem, I'm either going to do something to fix the heart rate, do something to fix the stroke volume, or do something to fix the resistance. Either of those fixes blood pressure. You see how when I get everything down to like simple things like that, no matter how complicated the patient is, I can always figure out what I need to do. Does that make sense, everybody?
Mm-hmm.
Okay. Now, Winchell, how do you like thinking like that as opposed to just knowing random memorized facts?
Well, from like knowing, memorizing facts, you're just memorizing a lot of pieces to it. But like when you talk about it, you bring it together like a puzzle.
Okay. I don't want you having just random dots. I want you to know how it's all just carefully integrated. Notice how we were talking about like vitamins, and I tied that back into aspirin overdose.
Mm-hmm.
Okay. You constantly want to know how everything is integrated. Now, so let's just recap this. So, Logan.
Yes, sir.
Logan, come off mute for me. You ready?
Mm-hmm.
All right, since you asked for this, it was your fault. There I was, just minding my own business. Let's go, my man. Let's say we've got an opiate overdose.
Mm-hmm.
How are we going to fix it?
Well, you're going to start with a BVM connected to oxygen.
All right, so we're going to go BVM. We're going to go O2 plus some kind of airway adjunct, whether that's an OPA or an NPA. Boom. Now, that's an opioid overdose. Now, after then, what else are we going to do medication-wise?
You can administer Narcan, preferably intranasally.
Also known as?
I have it in the back of my head. Naloxone.
Say naloxone. Okay. All right. Naloxone. How does it work?
It binds to the.
Does it competitively or non-competitively? Does it compete or doesn't?
It competes to bind with the mu receptors.
So it's a competitive inhibitor for the mu receptor. Okay.
Mm-hmm.
So it's a competitive inhibitor for the mu receptor. That's how you want to know Narcan. What's the dosage of Narcan?
It's 0.4 to 2.
0.4 to 2 what?
Milligrams.
0.4 to 2 milligrams. How are we going to give it?
Intranasal, preferably, but it can go
preferably
IV, IO,
intranasal.
IM.
That would be the way, because it's going to work the fastest of all the routes, and it's kind of the safest because oftentimes you don't already have an IV established. And of course, we could give it IM as well. It could be given a lot of ways. Intranasal would be preferable. Okay, what's that device called that we use to squirt it up their nose?
A atomizer.
Man, check you out. Atomizer. Okay, so sometimes it's called a MAD device or a DART, a mucosal atomizer device. So what we're trying to do is we're trying to atomize or make a fine mist that can get across the mucosal surfaces. Where do we have a lot of mucosal surfaces in the body?
The nose.
Okay, the way you want to think of it is this is any place that's sticky and wet in the body. So that's going to be the nose, that's going to be the mouth, that's going to be the vaginal canal, that's going to be the butt, so that's going to be the rectum. Okay, any of these places are sticky. Now also, these happen to be like sexual places. Okay, the nose, the mouth, the vaginal canal, the rectum, these are all kind of sexual places, but they're mucosal surfaces. This is why when fluids cross over these surfaces, it's very easy for things to get absorbed. So like if a virus or bacteria crosses over these surfaces, it's very easily, this is how a lot of sexually transmitted diseases happen, is the bacteria or the virus is very easily crossing this surface, okay, this mucosal surface. And because it's sticky, like once it attaches there, it just kind of stays there. All right, so that's opiate overdose. Let's go. We went over benzo overdose. Logan, what's our treatment for a benzo overdose?
It's going to be flumazenil or
Flumazenil. This is the
Romazicon.
overdose. What?
Romazicon.
Flumazenil, also known as Romazicon, flumazenil being the generic name. You want to know all the generic names. So flumazenil is the generic name. Naloxone is the generic name. Okay.
I learned that the hard way.
Give me some examples of benzos.
Versed.
Okay, Versed is a trade name. What is the generic name? Midazolam. What else?
Diazepam.
Diazepam. Diazepam is the generic name for the trade name Valium. Give me another one.
Oh boy.
What is lorazepam? That's the trade name Ativan. Okay. So midazolam, diazepam, lorazepam, lots of these. Okay, no problem, Cody. So these are benzos. When do we use benzos?
Seizures.
Okay, so anti-seizure medication. What else do we use them for?
You can use them for like excited delirium, stuff like that.
Okay. We can. What else? Procedural sedation. Now, when do we have to, what kind of procedure might we need to sedate somebody? So it can be used as a part of RSI for rapid sequence intubation or induction for you need to intubate somebody. It's not even rapid. It's like it takes several minutes. But how about synchronized cardioversion?
Right. Yeah.
You're about to cardiovert an unstable symptomatic tachycardic patient. If time permits, you want to sedate them because you're about to light them up with electricity. I'm somebody who's personally been cardioverted. You don't want to remember this. How does a benzo actually work? This is crazy. We can go from anything to anything real quick. How does a benzo work? You guys want to know this or no?
I know it's more of like it's like a calming mechanism, almost like a dissociative type deal.
Like suppresses.
Okay, now, dissociative is the word. When you say the word dissociative, you want to think ketamine for that.
Right.
Okay, so it is an amnestic where it wipes out your memory, but I need you to tell me, how does it do what it does? And the reason you want to know how and why medicines work, because if you just have level 1 knowledge where you know what something is, oh, this is called a seizure. Level 2 knowledge is what do the protocols say do about it? Oh, seizure, benzo. That's most paramedics. You got to get to level 3 knowledge where you understand the how and the why, because now you're able to anticipate side effects or adverse reactions. You want to know how a benzo works? Well, since you begging, man, let's go.
Yeah, absolutely.
Let's go. Are you guys good if I go over this?
Yeah.
Let's go.
Garrett, what you say? Because if Garrett says no,
Oh,
the
yeah.
answer is no.
No, I'm good with it.
Oh, dang it.
I'm interested to see if what I'm thinking is right.
I tell you what, you tell me what you're thinking, man.
I mean,
that's Christian
I'm probably-
talking. Christian, what you think?
Let's
go. Let's hear it.
I'm probably wrong, but
Or be right.
or be right. I never know.
Let's go.
I feel like a benzo is connecting to like a muscarinic receptor, which then creates like a parasympathetic response in our body. Maybe.
So atropine and ipratropium are primarily going to be the muscarinic ones. You're on the right track. I mean, you're kind of on a similar track, but that's not exactly correct. That's okay. Keep going though. Where else would you go with this?
I mean, it's got to bind to some sort of receptor that.
Yep, that sounds good. It's got to bind to something, right?
Yeah.
All right, let's go here. Let me help you out, my man. All right, so let's go over benzo. How does it actually do what it does? Okay. Now, we said that benzos are used in the place for, you got a seizure patient. They're actively seizing. We're going to give them some benzo. We're going to give them midazolam, Versed, something like that, or whatever your protocols call for. But this is how benzos work. Okay. So here's what's happening in the body. Here's a cell, right? And remember, cells go through 3 phases, all cells in the whole human body. So you learn these words like depolarization, repolarization, but you learned it in the setting of an EKG. And they told you that the P wave represents atrial depolarization. And then they told you that the QRS represents ventricular depolarization. And then the T wave represents ventricular repolarization. How many have heard that kind of stuff before? Okay. Well, it was taught to you by most people just in the setting. It only came up. The only time you even used those words like depolarization, repolarization, was when you were talking about EKGs. Depolarization is not an EKG situation. It's a cell situation. It happens in every cell in the whole body. So here's what's actually going on behind the scenes. When the cell is at rest, it has a very negative charge. Okay. But in order for the cell to get excited and do whatever it's supposed to do, it has to somehow become very positively charged on the inside. It could be due to sodium rushing in. Sodium has a positive charge. When sodium rushes into the cell, now we get a lot of positive inside the cell. It could also be due to calcium influx, where calcium rushes into the cell, and now we get calcium with all of its positive charge. Either way, when the inside of the cell becomes very positive, the word for that is called depolarization. What does depolarization mean? Oh, it just means that the inside of the cell became very positive because something went in with a positive charge, whether it was sodium or calcium. But now, let's say if we have this depolarization, too much positive activity. In the brain, when I have too much positive activity happening, oh yeah, let's put a whole bunch of positive stuff going on inside the cells of the brain, the neurons. Oh yeah, the word we use for that, that's called a seizure. What's a seizure? It's just too much depolarization of the brain. Let's take that same concept and apply it somewhere else. Let's say if I'm in the heart. What if I have too much positive stuff going on? Well, what if I have a whole bunch of calcium going on in the atria of the heart? Oh yeah, that's going to cause all kind of atrial tachyarrhythmias. Oh, that could be wandering atrial pacemaker, multifocal atrial tachycardia, supraventricular atrial tachycardia, paroxysmal supraventricular atrial tachycardia, atrial fib, atrial flutter. All of those tachyarrhythmias are just too much depolarization in the atria. But what if I have a ventricular tachyarrhythmia where I got too much depolarization happening due to too much sodium influx in the ventricles? Oh yeah, that causes ventricular fibrillation, ventricular tachycardia, monomorphic ventricular tachycardia, polymorphic ventricular tachycardia. Okay, so all those is just too much depolarization, too much depolarization. What if I have too much depolarization happening along the intestinal tract? What do I call that? Oh yeah, that's called diarrhea. What if I have too much depolarization here in a muscle? Oh yeah, what's that called? That's called a muscle cramp. What are all these situations? Depolarization, 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 depolarization. What is depolarization? Oh yeah, too much positive activity inside the cell. So in a seizure, if they're having a seizure, the reason I need to give them a benzo is they got too much positive stuff going on into the cell. How can I get rid of positive? Well, I can either, if positive is on the inside, I can pump positive out. Okay, so watch this. Let's get rid of some of this positive. Because if I'm trying to make it negative, I can get rid of positive, right? Does that make sense?
Yeah.
So is lactic acid of
Hold on, hang on a second. Because I'm cooking right now, man.
yeah, sorry.
No, I just need to complete my thought. So let's make some sense of this. I only have 2 ways that I can make the inside of this cell go from very positive to negative. How could I do it? I either pump positive stuff out, or how else could I make the inside negative?
Bring negative stuff in.
Potassium.
And check you out. What? I mean, you want to just take over? What if I just pump negative stuff in? Okay. Because that could, if I pump a whole bunch of negative stuff in very quickly, the inside becomes very negative. That's exactly what I need to happen to stop this seizure. Well, what molecule or what electrolyte has a negative charge? Oh, yeah, that's chloride.
Pass.
No, potassium has a positive charge. Potassium is on the inside of the cell with a positive charge.
Okay.
Sodium is on the outside of the cell with a positive charge. Calcium is on the outside of the cell. So sodium, potassium, and calcium all have a positive charge. It's just potassium is what's called intracellular, meaning that it hangs out inside the cell. And then sodium and calcium and magnesium and phosphorus, well, not phosphorus. Sodium, calcium, magnesium are extracellular, meaning they hang out outside the cell at rest. So if they're having a seizure, the way I can stop all this positive inside the cell is pump some negative in real quick. That's going to be chloride. So remember that. What is the electrolyte that has a negative charge that if I can get it inside the cell real quick, I can slow stuff down? What's that electrolyte called?
Fluoride.
Chloride. So now let's tie this into a benzo. Because some kind of way I gotta get a whole bunch of negative, like chloride, inside through a chloride channel, and then boom, boom, negative, boom. Now I just stopped the seizure. Do I have a drug that can help me activate this? Oh yeah, that's a benzo. So this is the way a benzo works. Do I look like I get excited about this?
Yeah.
Seriously? For real?
Yeah.
Yeah, absolutely.
Okay. Well, cool. I actually do. So this is the way a benzo works. On this chloride channel here, let's clean it up a little. Let's just do it over. Here's your cell. Here's your chloride channel. Okay. On this chloride channel, there's what's called a GABA receptor. GABA receptor. What is GABA? Gamma amino butyric acid. Another way to think of it is the kill switch. It's the emergency brakes, the emergency shutoff for especially the brain. Okay, so it's what's called an inhibitory neurotransmitter. Neurotransmitters are ways that signals move along nerves. They transmit a message along a nerve so that something happens. You either speed things up, that's called a stimulatory neurotransmitter, or you slow things down, that's called an inhibitory neurotransmitter. In this case, if they're having a seizure, they got too much activity, I need to slow it down, so I need to inhibit something. And the best one that I could use, I might as well use the whole emergency shutoff switch for the body. That's GABA. So here's what it is. So the black thing is the cell. The blue thing is the chloride channel. The green thing is the GABA receptor. And then let's put in pink, let's put GABA. And I should have said GABA is the inhibitory neurotransmitter, but the GABA receptor is what GABA binds to. So let's erase this part. All right, so let's make sense of all this. The benzo activates GABA, which is the shutoff switch. GABA, so the benzo activates GABA. GABA attaches to the GABA receptor. The GABA receptor is located on the chloride channel that opens up the channel so that now a lot of chloride flows into the cell. That's how the seizure gets stopped. We have two ways we can do this. One of them is with a benzo. The other is with a barbiturate. Okay? Both of them work on chloride channels. Both of them activate GABA. They just do it in different ways. The benzo increases the frequency of the channel opening. That's just a fancy way to say we open the door faster. Either way, okay, if I open the door to the chloride channel faster, chloride rushes in quickly. Either way, it becomes negative on the inside of the cell. Barbiturates, what they do is they increase the duration. And the way I like to say this is barbituration. barbiturate. So barbiturates like phenobarbital, secobarbital, pentobarbital, they increase the duration of the chloride channel opening. What am I saying? One of them keeps the door open longer. This one keeps the door open faster. They both open the door. Either way, once the chloride door opens, because GABA binds to the GABA receptor on the chloride channel, opens up the door, whether we open it fast or we keep it open longer. Either way, once the door gets open, chloride rushes into the cell. The inside of the cell becomes negative. That's how a benzo works. Who wants to take it? Christian, is that what you were thinking?
Well, I had a quick question. When you said, if you go up a little bit on your screen, I forgot exactly. Okay, so when you're talking about a muscle cramp,
yeah,
and there's too much positive, does that mean that lactic acid, because they say, oh, lactic acid is building up in your muscles, that's why you have a cramp. Does that mean lactic acid makes the cell more positive? Is that what causes it to be more positive to cause the cramping?
So it's not so much the lactic acid, but okay, so what happens here? First of all, okay, hold that thought. Like, okay. I know the answer, but hold that thought for a minute. Yep. Let me finish the conversation on benzos. Remind me to come right back to lactic acid. I'll draw it out for you. So, Christian, tell me how a benzo and a barbiturate work and why we give either one of those in the setting of a seizure.
Yeah, so when you have a seizure, you have your cells that are way excited. They've got a lot of positive inside. When you introduce a benzo or a barbiturate, it has, it opens, what's the channel called again?
The channel is you guys help him out. What's the channel called?
The chloride channel.
Chloride channel. And what's attached to the chloride channel?
GABA receptor.
GABA receptor. And what binds to the GABA receptor?
GABA.
Okay. So a benzo enhances the activity, or like it activates GABA. Benzo activates GABA, or barbiturate activates GABA. Okay. Both of them activate GABA. And GABA binds to the GABA receptor. The GABA receptor is attached to the chloride channel. It turns on the chloride channel. And when it turns on, what rushes inside the cell?
Chloride.
Chloride has what charge?
Negative.
So if it has a negative charge and I pump a whole bunch of something with a negative charge inside the cell, what does the charge of the inside of the cell now become?
Negative.
And that's the way I counteract all that positive, i.e. I stop the seizure. Does that make sense? And the reason we go that route is it's the fastest way to get us there, because it's like I said, it's the shut-off valve. Like, yeah, there are a lot of things that I could do to slow things down. But when it's the brain involved and it happens to be the most important organ, I might as well go straight for the kill switch. Make sense? That's why I'm going to I'm going to go with a heavy hitting thing like GABA. Because I could have done it with a sodium channel blocker. I could have done it with a calcium channel blocker. They just take too long. And when they're having a seizure and the brain is cooking, I need it to stop in seconds. I might as well go straight for the source. Okay.
And why would we give a benzo? Why would we give a benzo instead of a barbiturate in, let's say, the field, if the barbiturate we know is going to keep that channel open longer so they don't go back to having a seizure? Why would we try and just we're always trying to use something that
because, well, exactly what you're saying. Because of the half-life involved, because it's going to keep that door open longer, it's going to cause negative to go too long. And when, so let's say if I have a whole lot of negative, the short answer is the benzo works faster. And it doesn't last as long, because if I give too much benzo or too much barbiturate, I can have the opposite effects. So let's say I have too much benzo or barbiturate. Let's say I give either one of these drugs. Well, now let's say I cause a whole bunch of negative, and the word for that is called repolarization. Let's say I cause a whole bunch of negative now in the brain. But let's say I have a lot of repolarization that happens in the brain stem. Oh yeah, that's where my respiratory center is. And if I cause a whole bunch of repolarization happening here, now I turn off my respiratory center. Oh yeah, when I turn off my respiratory center, what's that going to cause? Oh yeah, that's going to cause respiratory depression, or let's call that respiratory depression. Respiratory, let's make that purple. Respiratory depression, respiratory failure, eventually respiratory arrest, eventually cardiac arrest. You've seen this pattern before, right?
Mm-hmm.
This is why when you give any benzo, you need to be prepared for intubation, because you may cause respiratory failure, respiratory arrest, cardiac arrest. This is why every patient who gets sedated or medicated like this, you need to have them on the monitor. You need to have IV access. You need to already have your intubation supplies ready to go. You need to definitely be monitoring their end-tidal CO2, because I know that with ventilation problems, I'm going to slow down respirations. They're going to hold on to CO2. CO2 is going to cause acidosis, put them in vasodilation, lead to shock, right? Does that make sense?
Absolutely.
Okay. Now, you teach this back to me. So I need you to teach me how benzos work and how barbiturates work and why I use them for a seizure.
Are you talking to me?
Yep.
Okay, so when somebody is having a seizure in the cells, there is a lot of positive charges. When you introduce a benzo or a barbiturate, you open up the channel.
What kind of channel?
Son of a gun, why can't I ever remember the name? No.
Chloride.
Chloride.
Okay.
Chloride channel. So you open up the chloride channel.
But how do first, like, it doesn't start here. The starting point is here.
Yeah.
So what's the starting point?
So the starting point is allowing GABA to attach to the GABA receptor.
Okay. And
Which
then that in turn does what?
Opens the chloride channel. And then
now I got two ways to do it. I can either open it faster or I can keep it open longer. Either way, it's got to be open. If I open it faster, what drug does that?
Barbiturate.
Nope. Remember barbiturate?
Oh yeah, barbiturate's longer. Yes,
okay.
benzo is fast.
Barbiturate. So barbiturates keep it open longer. Benzos keep it. They open it faster. Either way, it opens, and then what rushes inside the cell?
Chloride.
Chloride. And then once chloride with its negative charge goes in, the inside of the cell becomes negative. That's called repolarization. So now we counteract the depolarization. Does that make sense?
Yep.
All right, you got it?
Absolutely.
All right, now go back to what was your question? Something about lactic acid?
Oh yeah, I was wondering if lactic acid would cause the cells to be more positive, and that's why we have cramps.
Okay, so here's what happens. So in lactic acidosis, so let's use this situation. So let's call this a muscle, and we're going to call this a skeletal muscle. By the way, what are my three muscle types?
Smooth, skeletal, and cardiac or cardio.
We have smooth, we have skeletal, also known as striated, and we have cardiac. Okay, cardiac muscle is found in what organ?
Heart.
Heart. Okay, that's the only place it's found. Skeletal muscle is found in your skeletal muscle, so what you typically think of as your muscles. Smooth muscle, where is it found?
Intestines.
Okay, so we're going to say GI tract. Where else?
Stomach, which is GI, I guess.
Okay, urogenital. So anything dealing with the urinary system, most of the reproductive is kind of smooth. Okay, so here's a muscle. Here's a situation in a muscle. When you start overusing your muscle, when the muscle is being used a lot. Hang on one second. Let's see. Let's make sure it's not that serious. Okay. When you're overusing the muscle, here's what happens. What do the muscles like? What's the muscle source of energy?
Probably ATP.
Okay, ATP, but what's its main fuel? Like, what does it need to eat to keep working? The muscle primarily runs off glucose. Well, primarily, what's stored in the muscle? It's going to be glycogen. And then that glycogen gets converted to glucose through something called that's called glycogenolysis. So anyway, we're trying to get to glucose. Why do we need glucose? Do you know why? How many of you have heard of something called the Krebs cycle?
I've heard of it.
Okay, so here's what happens. This is what happens in all cells in the body. So I'm on the inside of a cell. We need this glucose to ultimately, it's 10 steps here. You don't have to worry about it. This glucose needs to eventually go through 10 steps and get converted into something called pyruvate. Okay, this pyruvate then goes over to the mitochondria. Okay, and then ultimately what's going to happen is this pyruvate is going to go through, it's a whole bunch of steps here, but long story short is we're going to go through something called the citric acid cycle, citric acid or Krebs cycle. Then we're going to go over to something called the mitochondria, to the electron transport chain, and ultimately we're going to make ATP. Okay, long story short, let's do this again. Hang on, I'm trying to shrink my page down. There we go. Long story short, inside your body needs to convert glucose to pyruvate. Pyruvate needs to go over to the citric acid cycle. So it's a cycle that looks like this. There are 8 steps here. And it's going to make some other chemicals for us. Like, I understand it, but it's more than what you need to know at this level. Long story short, eventually, we're going to go over to the electron transport chain in the mitochondria. Long story short is we're going to make ATP. The whole goal is we're trying to make ATP for energy. Okay? That's what should normally happen. But this process requires oxygen. Oxygen is needed for all of this to happen. But when you exercise too much or you're fatigued or whatever, now you're running out of glucose. And if you don't have glucose, you can't have glucose to go to pyruvate to go through the citric acid Krebs cycle to make ATP. So what does your body do? It says, hey, I don't have oxygen now and I don't have glucose. So what I'm going to do is I'm going to use my other fuel source, my backup source. I got another way I can get us to some ATP. And that's go through the lactic acid route. Okay? When I go through this lactic acid route, I will make ATP, but instead of, like, if I go through the glucose route, I'm going to end up making about 32 ATPs. If I go through the lactic acid route, I'm going to make 2. Some is better than none, but I'd rather have 32 than 2. But in this situation, we end up with lactic acidosis. But because I'm not making enough ATP, I'm only making 2 of them. Every time this goes around, I only make 2 instead of 32. What happens is I start running out of ATP. You with me so far?
Yep.
Okay, so now I'm running out of ATP. My ATP levels are starting to go down. Oh boy, that was my main energy source. Why else do I need ATP? Well, because ATP is what's needed. Here, let's blow this up. ATP is what's needed to activate the sodium potassium ATPase, or sodium potassium pump. What's the job of the pump? When that sodium went into the cell with its positive charge, it goes out through the pump. Okay? It goes in just due to a concentration gradient. But the way it has to get out it has to be pumped out. In order to make the pump work, I got to have ATP. If I don't have ATP, the pump quits working. So now what happens? Now there's nothing to pump the sodium out because its job was to pump the sodium out, and then the potassium that leaks out through the potassium that leaks out through leaky potassium channels. So the potassium that was on the inside, it leaks out. But the way it has to get back in is through the pump. So when the pump quits, though, there's nothing, watch this, there's nothing to pump out the sodium. Hold on. There's nothing to pump out the sodium. There's nothing to pump back in the potassium. So now what happens is I get a whole bunch of sodium trapped on the inside with the positive charge. So your question was, in lactic acidosis, do I have a whole bunch of positive charge contributing to the depolarization? Yes.
Mm.
Okay. But this is why. Does that make sense, what I just said?
Absolutely.
All right, hit me with that back so I know you're getting it.
Okay. So, when you're working out,
All right, yeah, let's start there. So we're going back to working out, okay?
Yeah.
Mm-hmm.
So when you're working out, your muscles need need glucose. The
Okay, and where does
glucose,
that glucose come from? What's the source of energy that's stored in the muscle?
uh,
Glycogen.
glycogen
Okay, and that glycogen gets converted to glucose. And why do I
through
need
glycogen.
glucose? Because glucose goes through, oh, by the way, this process of glucose going to pyruvate, that's called glycolysis.
Glycolysis.
It's a 10-step process called glycolysis. Okay. But ultimately, glucose goes to pyruvate. Pyruvate gets used in the Krebs cycle so that we can pass electrons through the electron transport chain and make some ATP. And if I do that right, I'm going to make how many ATPs net?
32.
Okay. Which is great because now that's a way I can get quickly energized. However, when I use up all my glucose, because I only have so much glycogen stored, and if I go run a marathon or I do something that uses up all my energy, I got to find another way to make some more energy. So your body switches over to lactic acidosis or uses lactic acid for energy. The problem is it makes ATP, but how many does it make?
2.
It makes 2. So it doesn't make enough. And I'm using it faster than I'm making more. So just like if I use my money faster than I make more, I run out of money. So now I run out of ATP. And why is that a problem? So what do I need? Where do I need ATP to work?
Yeah, so the sodium potassium pump needs ATP
Sodium
to work.
potassium pump or sodium potassium ATPase. What's the job of the sodium potassium pump?
To allow sodium to exit and potassium to come back in.
Nice. And how many sodiums go out?
Isn't it 3?
It is.
Yeah.
It's 3 sodiums out. How many potassiums in?
2.
It is 2 potassiums in. Okay, cool. But when the pump quits because I ran out of ATP, what happens to the sodium that's inside the cell?
Builds up, stays in there.
Okay. So now I got a whole bunch of sodium inside the cell. You know what sodium likes more than anything? Its cousin, chloride. So now I have wherever there's a sodium, there's also a chloride. So when I put sodium and chloride together, what does that form?
Sodium chloride?
Which is called?
Salt.
Salt?
And what does salt like more than anything?
Fluid?
Water.
Water. So now when salt gets trapped in the cell, water gets trapped in the cell. Now, if I keep putting more and more water inside the cell, what happens to the size of the cell?
Grows.
Huh?
It grows.
It gets bigger. And when I keep getting it bigger, 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 what is the word for that call? When the cell gets inflamed?
Diluted?
Oh, yeah.
No.
That's called inflammation. This is how all inflammation in the whole body happens. Winchell, you look like you just had a moment.
Yeah, when you was going over it, some stuff clicked.
Like what? Let's hear this.
Like when you was saying with the trapped sodium, it likes the chloride, and then it made salt, and then the cell starts soaking in the water, and then it started to grow, and then now you have inflammation.
Come on, man. Hit me one good time with that. Let's go.
Yeah. So
all right, give me that whole thing. Give me that whole song again. So you got to get me from lactic acid to the cell becoming more positive, because that was his original question. He said, if in lactic acidosis, does that contribute to more depolarization of the cells? Absolutely. Okay, but connect all that for me. So start me with where you can. Start me with a muscle and what's stored in the muscle.
All right, the muscle has glycogen. You try to convert it into glucose, and then Glucose goes into it's
Pyruvate.
pyruvate. That's glycogenesis.
That's no, that's glycolysis. That part is called glycolysis.
Glycolysis.
Uh-huh.
Okay. Uh,
And then
then you burn that. So you're burning the the
so
glucose.
here's what it is. We go from glycolysis to pyruvate. That process is called glycolysis.
Glycolysis.
Then we go,
yeah.
this pyruvate enters into the citric acid cycle. So let's say, or sometimes it's called Krebs cycle, named after Dr. Krebs. Then what we're going to do is we're going to, eventually we make electrons through that, and those electrons get passed through what's called the electron transport chain. So it's this chain, it's this cluster of electrons. They get passed around, and then the end product right here is we make ATP. If we do it right, we end up with 32 ATPs. However, if in like once we use up all of our glycogen, we don't have glucose available. Oh, and this should have been glucose. Okay. If we don't do that process, then what we're going to do is we're going to go from lactic acid, and we're going to take lactic acid and
Which
pass
only
it
has
through.
2.
Okay, we're going to pass it through the Krebs cycle and then the electron transport chain, but it only makes 2 ATP. Okay? So eventually we're going to run out of ATP, and then how does that affect me? If I run out of ATP, I can't power up the what?
The sodium potassium pump.
Sodium potassium pump, also known as sodium potassium ATP ACE. Okay? And what's the job of the sodium potassium pump or sodium potassium ATP ACE?
Take in potassium and push out sodium.
Okay? Bring potassium back in and push out sodium. The sodium came in through the sodium channel, and now it's in. So let's say here's my sodium, but the way it has to get out is through the pump. I got to pump it out. But when I run out of ATP, the pump don't work. So now my sodium gets trapped inside the cell. What else does it like in there with it?
Chloride.
So we got sodium, then we have chloride. And what do those two make?
Salt.
Oh, wait a minute. Sodium chloride. I heard there was an electrolyte. I heard there was an IV fluid that's made up of sodium chloride. What's that called?
Lactate ringers.
No. The one that's just sodium chloride, the one that's just salt and water is saline. Saline is just salty water. So
yeah.
So this is our salt water. Well, this is our salt, but what is salt like more than anything?
Water.
Water. So now I've got sodium chloride and water. So now I got salty water. And then as I get more water inside the cell, what happens to the cell?
It expands.
Cell gets bigger. That's called inflammation. That's how every inflammation, no matter what I call it. But if I have it in the brain, we call that increased intracerebral pressure. If it affects the optic disc, we call it papilledema. Okay. If it's in the heart, we call it carditis. If it's in the liver, we call it hepatitis. If it's in the muscle, we call it myositis or rhabdo. If it's in the pancreas, we call it pancreatitis. All of these itis is just inflammation due to exactly this. Does that make sense?
Yeah.
How you feel about that, my man?
I got to play with it a little bit, but I'm getting it. Everything's clicking.
Okay. How about you hit me one more time? You do. All right. This is all you now.
So, where you want me to start?
Need a picture or no?
Yeah, I'd probably need a picture.
All right. Where you want to start? How about we start here?
Okay.
So start me with the muscle.
So the muscle has the muscle uses glucose, and then once you get the glucose, you go through glycolysis. Am I saying it right? Glycolysis. Okay. So glucose goes into it's a 10-step process. It goes to the
Okay, here, let me write these words for you. Pyruvate.
All right, pyruvate. And then it goes into the 10-step system to make of ATP, which
Well, so this is an 8-step process called the Krebs cycle,
Krebs cycle.
okay, or the citric acid cycle.
Citric acid, Krebs cycle made by Dr. Krebs.
Uh-huh.
And then you get ATP. No, you get ATP 32.
You do end up with a net of 32 ATP.
Okay. Once you use all that, then you start to use like the lactated acid, and that gives you an ATP of 2.
Yep.
Which eventually you're going to run out.
Run out of what?
You're going to run out of ATP.
When I run out of ATP, what happens?
And then that's going to kill your potassium, sodium potassium pump. That's going to kill your sodium potassium pump.
Okay.
All right. And what that does is it pushes out sodium and it takes in potassium. So once you kill that, you have all this sodium, and then the sodium likes chloride, and then that's going to create salt inside of a cell. And what what salt likes is water, and it's just going to bring in all that water, and it's just going to blow up that cell, which is going to cause inflammation.
Now,
And
let me show you
with
what
the
else
inflammation.
happens. Let's add one more step to this. With all this inflammation, there's this membrane that goes around the cell. Well, now, when I have all this inflammation, I'm going to destroy my cell membrane. So the stuff that was supposed to stay inside the cell leaks out. The stuff that was supposed to be outside can leak in. So this is why, let's put it in purple. Let's say I have all these enzymes inside the cell. So let's say I'm talking about the heart. Somebody's having a heart attack. Well, let's say there's an enzyme called troponin. Well, now, when that enzyme can leak out, that enzyme can now make its way into the blood. And this is how, in a heart attack, we end up with elevated troponin. It gets detected in the blood because the cell got damaged. Due to a loss of ATP, the sodium got trapped inside the cell. It brought in chloride with it. Then we attracted water in there. The cell started to swell. Then the membrane damages, and now we end up with cell death. But now the stuff that was inside, like the enzymes, start leaking out. They make their way into the blood, and now I can measure it in the blood. And when I get more and more enzyme that gets into the blood, now my cardiac enzymes are elevated, like my troponin is elevated. Okay, does that make sense?
Yes.
Okay, how you feel about that?
Feel good. Troponin is what? The protein? It's a protein?
It is a protein, but more specifically, it's an enzyme. Yes, enzymes are proteins, but you want to call it an enzyme. Okay.
I never knew that the troponin levels are because the cells are dying and releasing the troponin into the bloodstream, and that's why they're elevated, which makes sense because when you're having a heart attack, part of your heart's dying.
Yes. And troponin is one of the things that's needed for the muscle to contract. Troponin binds to calcium through something called the tropomyosin complex. You don't need to know that. I'm just showing off now. No, I'm actually not, but that's really what happens.
It's not just calcium that makes the muscle contract. It needs the troponin as well.
Since you want to go there. Okay, let's go. How does a muscle contract? What's needed for a muscle to contract?
Calcium.
Okay, so I like that. Why? Because that's level 1 knowledge. Remember, there are 5 levels of knowledge. Level 1 is just what something is. Level 2 is what do the protocols say? That pen is way too big. All right, let's do that over. So level 1 knowledge is just what something is. Level 2 is what and the protocols. Level 3 knowledge is the how and why. That's when you become dangerous in the best way. Okay, level 4 is where you're able to apply something from one part of the body to something else. And the highest level of knowledge is mastery. Okay, you don't want to be a level 1, level 2 kind of person. You need to be higher toward mastery. We may never get there, but we need to be constantly getting closer. So I'm asking you, how You said what? You said a muscle needs calcium to contract. Tell me how and why. Get me there.
Well, in a cell, when you add calcium into the cell, it's going to become more positively charged.
Okay, hold on. So what you're saying is, okay, here's a cell.
hmm
Calcium has to go through a calcium channel.
hmm
Calcium that was on the outside has to go to the inside. Now I
hmm
get calcium on the inside. Okay.
hmm
But somehow or another, you got to get me from muscle to, or you got to get me from calcium to this muscle contracting. Help me.
That's tricky. I'm not sure if I know.
It's not tricky. It's
I mean,
straightforward.
calcium, like, is it just calcium? So it's positive. So it's like an active process. So that's what
It
it's
is an
doing.
active process. Okay, I
So,
like that. What else?
yeah.
Detail, I think you own something. Let's keep going. All right, so here's what happens. Here's your muscle. Let me draw it this way. So let's say this is a muscle. Oh, sorry. We're just going to call this little line right here, we're going to call this the muscle. Okay, on the surface of this muscle, so this is what's called, so the membrane, every cell, remember, has a membrane around it. When I'm talking about a muscle cell, so what's called a myocyte, this particular membrane has a special name, and that name is called sarcolemma. This is way beyond what you need to know for registry, but I'm just explaining it to you. Okay, this is what's called a sarcolemma. But in order for, because what I need is I need calcium to make it, calcium is on the outside, and I need it to somehow get on the inside. Well, the way it's going to make it inside is through these things. So instead of when it's a muscle, it's not really called a, I mean, you could call it a calcium channel, but it has a specific name. And that name here is what's called a T-tubule. Okay. So here's what happens. Calcium binds to the sarcolemma. It travels through, to get from one side to the other side, it has to travel through the T-tubule. Then once this calcium travels through this T-tubule on the sarcolemma, calcium is now inside. What does the calcium do? The calcium is now going to bind to something. So here's calcium. Let's just put it in like a dot. There's calcium. Calcium is going to bind to something called troponin. Okay, so this is troponin. Now this troponin has to hook up to the troponin. That's your troponin. Let's put calcium there. Oh, I had it in pink. There's your calcium. This is your troponin. And then the troponin has to now hook up to something called the tropomyosin complex. Oh, sorry, you didn't see what I did. Okay, let's do it again. Let's go back. Watch me here. Calcium is on the outside. It's got to get inside. On the membrane of the muscle, that's called the sarcolemma. Inside the membrane, there's something called a T-tubule. The calcium goes through the T-tubule, and now once it's inside, the calcium now binds to the troponin. But this troponin now hooks up to something called the tropomyosin complex. And then once troponin hooks up to the tropomyosin complex, it's now going to activate, because in order for this muscle to contract, so when we say contract, it's where the muscle gets shorter. In order for it to do that, this is the way it looks. You have thin filaments. You have these really thin filaments called actin. And then have these very thick filaments called myosin. So that's called myosin. And then once these two things meet, once myosin and actin meet, they slide past each other. Once the actin and the myosin meet, they slide past each other, and that is what we call contraction. Okay? Now, let's go back over it again. because this, like, I don't think I've ever done this with any paramedic class. This is what I would do with medical students. But let's go back over it again. How does a muscle contract? This is the physiology of muscle contraction. Let's go. Calcium is on the outside because remember, calcium is always extracellular at rest. It has to get across this membrane. The membrane in this muscle is called the sarcolemma. Inside of the sarcolemma is the T tubule. And I actually forgot a step. It's where when it goes through the T tubule, it activates what's called the ryanodine receptor. Anyway, calcium activates the ryanodine receptor. Then this calcium binds to troponin. And now once I have calcium and troponin hooked up together, specifically it's troponin C, then this troponin now activates the tropomyosin complex. And the tropomyosin complex now activates, it allows the myosin and the actin to interact. They slide past each other. That's what makes the muscle contract. So yes, people say calcium is needed for muscle contraction, but look at all the stuff that actually has to happen between calcium and muscle contracting. Make sense?
Wow. Yeah.
Now, what is needed to make so calcium is ultimately needed. So to make the muscle, to make the muscle contract, we need it. Here, let's keep my colors consistent here. To make the muscle contract, I need calcium. But what do I need to make the muscle relax? Because once this actin and myosin slide past each other, calcium is what was needed for that. But I need them bad boys to break apart and go back to their original position so they can contract again. What is now needed for them to relax?
Muscle relaxant.
But they don't take a muscle relaxer, but they have a natural muscle relaxer. And what's that called?
I go back to our chloride.
That's called ATP.
Oh, ATP.
Okay. So this is why when somebody dies, there's nothing to make ATP. So the muscle contracts and it stays contracted. What's that called?
Rigor mortis.
So rigor mortis is a loss of ATP.
Interesting.
And the muscle stays contracted. Check me out.
Wow.
Was that pretty cool?
Very.
Okay. Now, I want you to hit me one good time with muscle physiology. How does a muscle contract? Don't tell me calcium is needed. Of course we know that. But tell me what happens.
So calcium is on the outside, and then it passes the sarcolemma through the T tube.
Okay.
Once it goes in there, now it's inside the calcium. And what was that step you forgot again? It activates what?
Ryanodine receptor.
Ryanodine.
Ryanodine.
Ryanodine. Okay. So it's RYAN, like Ryan, O-Dine. Ryanodine. And it's a ryanodine receptor. Okay. Okay. Once that happens, then this calcium now binds to what? Troponin. Okay. And it's specifically troponin C. You have three different ones. You have a troponin C, a troponin I, and a troponin T. This is the troponin C. The one that we're measuring in a heart attack is the troponin I. Some people think that's a troponin 1. It's a troponin I. Okay. That's going to be a troponin C here. Okay. Now we have troponin C and calcium. They're going to activate the what?
The troponin myosin.
Complex. So it's tropomyosin.
Tropomyosin.
Complex. Okay. And this tropomyosin complex now causes, it now activates the tropomyosin complex. Oh, I can't move it, but anyway, right here. It now activates this myosin.
And the actin.
And it allows the myosin and the actin to slide past each other. And when they do, the muscle shortens. That's called contraction. This is how all muscle contraction works, whether we're talking heart muscle contraction, smooth muscle contraction, skeletal muscle contraction. Calcium is needed for all of them. Okay. And then what is needed to make, so, and by the way, this is called a power stroke. Anyway, they contract. They slide past each other, they contract. But what do I need to come along to be able to relax this muscle?
ATP.
ATP. This is also why if somebody has some kind of chronic disease and they're not making as much ATP, or they're in a state of lactic acidosis where they're running out of ATP, now you don't have ATP to relax the muscle. So this is how a muscle cramp actually happens.
Hmm.
Is this making sense? Like, you like how I'm putting this together?
Yeah.
Okay. What questions do you have? Did I answer your question about muscle contraction?
Absolutely.
All right. You don't get any more questions today.
Sorry.
All right. What else? Hey, Jeff, how you doing, my man? Jeff don't want to talk to us. All right. So Logan, how was today? We're over on time now. So how was today?
It was good. It was very informative. I learned a lot. I have a lot
What
of
did you
notes here to
learn
go
today,
over.
my man? Now, okay. Now we're not going to hate on anybody. I promise we're not going to do that. But I'm curious. So you've used other resources before, right? And
Mhm.
you're using other resources now. What's the difference, really? For
I
the
mean,
people
it's
at home watching who are not in our community, what's the real difference of what you're getting in this community versus other people?
I really like, I mean, honestly, it's like not like the whole they just go through a PowerPoint and talk about it. It's more like it's broken down very nicely. It's very visual, which really helps to, commit that to memory. And also you making us teach it back really helps to commit that to our long-term memory as well.
Nice.
So it really helps.
And what you see me doing is exactly what I want you to be doing. You notice what I'm doing constantly is I'm talking and drawing, right?
Mhm.
That's really what you should be doing. You
Yep.
want to be talking. So when you're watching me on video, make sure you're talking back constantly. You want to draw these pictures, the same pictures that I'm drawing. The reason, like, people will look at me and they say, Coach, you're so smart. It's not that I'm smart. I mean, I'm not dumb. Let's not be confused. But do you know I've drawn these same pictures like 10,000 times? And so how is it that I'm literally sitting here right now with just an iPad and the same iPad, like, you see what's on my screen. I have no notes or anything. And you see how many topics we've covered today? Would that ever happen in your class? Like, where one topic would lead to 50 other topics in one session?
No, it's almost like a tree, kind of like you got like the main tree, and then you kind of take like the roots and
Okay.
kind of trickle them down a little bit.
Now, does that help though? When I go on these little paths, does that help you to see how other things are connected?
Absolutely, yeah. And I learned new terms and topics that I might have otherwise not known.
Okay. And this is what's happening inside the human body. When you go on a call, your patient is not a respiratory patient or an endocrine patient or a cardiac patient. Your patient is a patient where cells are going wrong. So it's very important that you understand things down to the cellular level, because that's where everything is happening. You notice how I keep drawing a circle and calling it a cell? Because that's where, like, did you notice how many times I drew a cell today? Where everything is happening down at the cellular level. We were talking about Narcan. It's working at the mu receptor on the cellular level. When we talked about benzos, we talked about benzos and barbiturates activating GABA and the GABA receptor on the chloride channel of the cell, right? When we talked about ATP, we were talking about glycolysis happening in the cell, glucose going to pyruvate, pyruvate going to citric acid cycle, passing electrons through the electron transport chain, generating ATP. All of that stuff is at the cellular level. Running out of ATP. Now sodium inside the cell gets trapped, brings in chloride inside the cell. Now we have sodium and chloride inside the cell, bringing water in the cell, causing the cell to swell, the cell membrane to burst, the enzymes leaking out of the cell. Notice I keep saying cell because everything in the body is working at the cellular level, yet most people don't know things at the cellular level. That's why most people struggle. What this allows me to do is when I understand the cell, I can understand anything better. Because just give me a cell, I can start with a circle and I can get to a lot of stuff from that one little circle. That's what I want you to be able to do. Okay. So hurry up, finish your other program for remediation and jump back in with us. Now,
Absolutely.
can you honestly, I'm not trying to put you on the spot, no pressure. I actually want you to be honest. can
Mhm.
you say that there's a real difference in what I'm doing versus the other program you're in? And there's no shade there, not at
Mhm.
all. We're just different.
Yeah, I mean, I think I messaged you about it. I think I like this program better because I feel like the other program is kind of just, it wants to focus on only the topics that it thinks are on the NREMT. But when I took the NREMT, whatever people think is on there is it's on there, but it's not completely, there's other stuff on there as well. Like you said with the cells, for instance. I didn't expect the NREMT to go very big into cells, but I had several questions asking me how certain pathologies affect different types of cells. Like, I mean, I think there was one about what cells HIV impacts, for instance. And I mean,
Okay.
I mean, I didn't know it at the time. I know it now. I mean, it's your T cells, your leukocytes, but I mean,
Okay.
I didn't know that at the time. So, and I didn't think I needed to know that until it came up on the test, and I'm like, oh, well, crap, maybe I should have known this.
So yes, it primarily affects T cells, T helper cells, and T regulatory cells, which are, you're right, they're types of leukocytes. And by the way, leukocyte is a type of what?
White blood cell.
What kind?
So white blood cell?
It is a white blood cell. How many types of white blood cells are there?
Oh Lord, a lot.
Okay. So when it comes to white blood cells, also known as leukocytes. Oh, by the way, that's not, you don't want to call T cells leukocytes. They are specifically called lymphocytes.
Okay.
So white blood cell, the word for white is leuco and cell is site. So white blood cells are leukocytes. There are 5 types of leukocytes, or 5 types of white blood cells. The way we remember this is never let mom eat beans. Because, mom eating these beans and you're in the car with her. Woo. So never let mom eat beans. Now, these are the 5 subtypes of white blood cells. The N is for neutrophils. That's spelled neutrophil. Neutrophils. The L is lymphocytes. Now, the types of lymphocytes is what you meant to say. Those are B cells and T cells. B cells and T cells are types of lymphocytes. Okay. These are what are needed for viral infections. So HIV, human immunodeficiency virus, is a viral infection that primarily affects B and T cells. Okay. So HIV primarily affects these B and T lymphocytes. Now, M is monocytes. Okay. These are also what are needed to make platelets. The E stands for eosinophils. Eosinophils are what are needed for allergic reactions. Allergic reactions and parasites. So if somebody has a parasitic infection, the type of white blood cell that comes on to help destroy these parasites, those are called eosinophils. And then finally, we have B for basophils. Okay. Oh, by the way, the neutrophils are the ones needed for bacterial infections, bacterial and fungal infections. So if somebody has if they have some kind of fungal, or some kind of bacteria, the main white blood cell that fights those is neutrophils. Let's go over that again. There are 5 subclasses of white blood cells. White blood cells are known as leukocytes. The way we remember that is never let mom eat beans. N is for neutrophils. These are the biggest, or not the biggest, they're the greatest number. The ones that are biggest size is monocytes, but the ones that are greatest in number are neutrophils. They fight bacterial and fungal infections. Lymphocytes are these are B cells and T cells that are involved in a lot of immune situations, especially viral infections. Monocytes make what are called macrophages, and they also make platelets. Eosinophils, they deal with allergic reactions and parasitic infections, so parasites. And then basophils are involved in a lot of other immune functions like mast cells and stuff like that, that deal with histamine and leukotriene, stuff like that. All I want you to know is 5 main white blood cells, and they're all helping fight some type of infection. So when the white blood cell count is up, it probably means they have some type of infection, but the way you figure out what type of infection, the doctor's going to order what's called a CBC with diff. That means a CBC, a complete blood count with a differential, and a differential is what specifies how many neutrophils, how many lymphocytes, how many monocytes, how many eosinophils, how many basophils. If you just do the CBC, it tells you red blood cell count, white blood cell count, platelet count, hemoglobin, hematocrit. But if you need to know like all the individual details, then they have to order a CBC with diff. So if you're doing a transfer and they say, you're looking through the labs and you see CBC versus CBC with diff, the CBC with diff is going to break down this stuff in greater detail. Does that make sense?
Mm-hmm.
Okay. All right, man, you're learning too much in one day.
That's what I'm saying. I was gonna say I'd love to go into this deeper one day when we're not over time, because I know my NREMT, I know it's different for everybody, but mine loved the cells. I don't know why. It just loved asking about cells.
Okay, now sometimes when you get in a whole lot of one problem, it's just because you're missing those.
Well, yeah, that too. I agree.
Okay. All right. So, but was today's session helpful?
Absolutely, yes. It was
You
very
asked a
informative.
question about overdose, and look where we went.
Yeah, right. Yep.
Okay. Go back over this, and for everybody, I'll put the replay up because this will be a good one for everybody to see again. Let's go to Winchell. Well, hold
Yes,
on.
sir.
Let's go to Garrett first. We're going to go to Garrett because Garrett, I hadn't heard much of you today. What was today's session like for you, my man?
It was good. It was a good review for the stuff that I needed to know. A lot of it was
yes.
lot.
Now, some of it is different than the AEMT level you're testing in advance, right?
Yes, sir.
Okay. But the testing stuff that I teach you in the 14 days program, it applies for every level to include EMT. So how are you on like the 5-star medic method?
I feel pretty good. I feel pretty good about that.
All right, tell me, what's the 5-star medic method?
The first one is safety. I have to draw it out real quick. I'm sorry.
Hey, that's
It
fine.
helps
In
me to
fact, I
draw
want you
it
to
out.
draw it out on your test, on your laminated sheet they give you. Draw it out. You want to draw out the 5-star medic method, the 5 things we do to take a test, and then the 5 triangles.
So a safety, sick or not sick, stable or unstable. And then it is fix
or support.
And the last one is
anything that's time sensitive.
Time sensitive.
Make sure
or
you know the
delayed.
5-star medic method because that's what you're going to use to answer questions on your tests, especially if it's a question about a patient. Now, if it's just a random question like how many white blood cell subcategories are there, the answer is just 5. You don't need the 5-star medic method for that. When is your test?
It is next Monday, the 10th.
Okay. So you definitely want to right now. You're within 6 days. You want to be doing the rapid drills immediately. Did you sign up at the pro level?
Yes.
Okay. So you want to, or did you sign up at Accelerator?
One of them.
Okay. Well, you have all the bonus resources, right?
Yes, sir.
Okay. You want to go through in the 21-day game plan, you want to be using the rapid drills like today. So start today. If you haven't already doing the rapid drills, they're designed for 7 days. There's an audio version as well as a written version. Use whatever you like, but definitely I want you to listen to the audio if you can, because you'll hear me saying this stuff over and over and over again.
Okay.
Then the other thing you want to do is go ahead and start using the diagnostic exams in Class Marker. Now, because we don't have as many advanced students, the tests right now are configured for EMT and paramedic. However, you should still, some of the things you may not know, but what I want you to do is just do your best. And what it'll do, I think you have 5 diagnostic exams and 2 final exams. So you've got 7 exams. Start doing at least one of those a day.
I've completed 4 of them.
You have already?
Yes. I've done 4 of them so far.
Okay. You definitely want to do final exam 1B and final exam 2.
Okay.
Because I'll be able to see your scores for that. And then I can kind of see where your weak areas are across all the different exams. I'll sort it out by category. And it tells me immediately, ooh, he's weak in acid base or weak in OB or whatever the case is. All right, so get those done over the next few days. How are you feeling overall?
A lot better than I have been. I mean,
Okay, and what attempt number are you on?
this is my last one. This is the last attempt I get.
Okay.
So.
And so I'll talk to you because perhaps it would be beneficial if you're an accelerator. You already get private coaching sessions with me anyway. If you're not, it may be worthwhile to do that, especially on this last attempt. We want to make sure you nail it. Okay.
Yeah.
All right. We'll be together again tomorrow and Thursday. If you have any questions, message me in school.
Okay.
Appreciate you showing up, my man.
Yeah, no problem. Thank you.
Yeah, no problem. All right. So, hey, Jeff, can you come in? Winchell, hold on for a moment. Jeff, are you able to come in?
Yeah.
Let's meet this Jeff guy. Hey, we've messaged a lot. I've never met you. How you doing?
I'm good. I'm good.
Where are you?
I'm in Florida, just north of Tampa.
Okay. Oh, Ocala. You're the one in Ocala.
Brooksville. So yeah, not too
Or
far.
you're testing in Ocala.
Testing in Ocala. Yep.
Okay, cool. Well, you came on, I don't know when you came on today, but how was today?
I came on like 30 minutes in. We had like 6 or 7 after midnight on the rescues, so I slept a little bit.
So, okay. How was today's session?
It was good. It was pretty in depth. Like I said, I've
You're
been watching a lot
testing
of the
at
videos. The paramedic, yep.
Okay, got you. Say that again about videos.
Yeah, just getting in depth with your videos and kind of how everything, ties in together. That's kind of how my style is,
Okay.
rather than, reading a bunch of sentences or PowerPoints.
And you're testing tomorrow?
Yes, sir.
Okay. All right. And so in your case, you and I have already talked, but I definitely want you to do your absolute best. Obviously, you miss a lot of stuff not being in the official program, but let's see how everything goes tomorrow. But either way, I think you'll benefit from getting in the program because, like I say, you don't want to be a 950 medic. 950 medics pass a test because they meet the minimum threshold. But when you woke up this morning, you didn't say, "Ooh, if I could just meet the minimums today, my life would be amazing," right? You didn't say that, or I hope you didn't say that. Because a real patient whose life is on the line, they don't need a 950 showing up at their door. They need a 3,000 level medic because a 3,000 level medic is going to be able to think differently. A 950 medic says, well, the protocol says do this. Sometimes you need to deviate from the protocol because if you do what the protocol calls for this patient with what they have going on right now today, you're going to kill them. But by me knowing more, sometimes I'm like, oh, wait a minute. This is one of those exceptions. I don't need to follow the protocol right now because this would be dangerous. And this is where I'm going to get on the phone with the medical director and say, hey, doc, I got this going on. If we do this, this is what's going to happen. Are you sure you want me to proceed with killing the patient on this recorded line? And they're like, whoa, let's not do that. I'm like, that's what I thought. So here's what I'm saying. I've never been denied an order ever in my whole career, but it comes from having a different level of knowledge and being able to articulate what I'm trying to get my message across. Does it make sense? And I want you to be able to do the same thing. You're going to get the best chance of that by going through the full immersion experience, because just watching like the YouTube videos, while it's helpful, it may be enough to just pass. It's not enough to be great. Does that make sense?
Mm-hmm. For sure.
Do you have any questions for me?
I mean, nothing really at the moment. There was like one section where you kind of talked about the different airway adjuncts as far as like, supportive care or you're actually fixing ventilation. And I remember when we were doing a review in class and they were deciphering, I guess, with the new ACLS standards as far as when to ventilate between like, the standard that everybody typically knows that they're below 94, you're given oxygen. But then you only give it if it's below 90. Just kind of the different levels of at what point would you give what. Obviously, if they're shallow and slow, you're ventilating.
Okay.
Just kind of deciphering the different ones,
So
depending on what you
there's
see.
one triangle we're going to use. All problems come down to what?
It's the oxygenation, ventilation, or perfusion.
Okay. Now, so remember, and I started talking about this today, we have ischemia, Then we have hypoxia. We have respiratory distress. Then we have respiratory failure. Then we have respiratory arrest. Oh, you're not seeing what I'm doing. Then you have cardiac arrest. Okay. Notice how I have these color coded. Everything in red is primarily a ventilation problem. Everything in blue is primarily an oxygenation problem. Everything in purple is primarily a ventilation problem. So the biggest thing you got to figure out is this oxygenation versus ventilation? Okay, that's what you're asking me. You're saying, how do I figure out an oxygenation versus a ventilation problem? Okay, an oxygenation problem, there are two things we do to fix an oxygenation problem. We either do something with the airway or we give them oxygen. Okay, if it's doing something with the airway, we only have like three things we do. We either open it, we clear it, or we keep it open. How do we open it? Head tilt, chin lift, jaw thrust. When do we do what? Head tilt, chin lift, medical, unresponsive. When do I do a jaw thrust? Trauma. How do I clear it? Well, I primarily clear it with suctioning. No more than 10 seconds for a kid, no more than 15 seconds for an adult. How do I keep it open once I have it open? With an airway adjunct, OPA or an NPA, unless it's contraindicated. What's a contraindication for an OPA? Gag reflex primarily. What's a contraindication for an NPA? Basilar skull fracture, head injury. Okay? O2. Because if I open the airway, now oxygen can get in. If I give oxygen, oxygen can get in. Oxygenation is all about getting O2 in. Okay? How do I give oxygen? Well, it's either mild respiratory distress, moderate respiratory distress, or severe respiratory distress. Mild respiratory distress, they're having trouble breathing, but they're able to talk. They're able to get out a lot more words. I'm probably going to give them a nasal cannula at 1 to 6 liters per minute. If I'm using a capnography nasal cannula, I'm going to go 1 to 5 liters per minute. Moderate distress. It's a little more effort. They may have some accessory muscle use. They're struggling a little more. Maybe they're talking in 3, 4 words, 2 words even. Okay, now I'm going to go with a non-rebreather. I'm going to go do that at 12 to 15 liters per minute. If they have moderate distress plus wheezing, I'm going to go with a nebulizer. I'm going to do that at 6 to 8 liters per minute. Now, what if they have severe respiratory distress? Well, now they're talking in one-word sentences, like they can only get out like 1 word at a time between breaths. I'm probably going to need to escalate to something like CPAP, unless it's contraindicated. What are my contraindications for CPAP? Not following commands, unresponsive, altered mental status, hypotension, vomiting, secretions in the airway. Okay? But that's how I fix an oxygenation problem. How do I fix a ventilation problem? Well, how do I know that they have a ventilation problem? Well, if they're in respiratory failure or respiratory arrest, those are ventilation problems. How do I recognize respiratory failure? Well, not only are they short of breath, they're probably altered. They probably have altered mental status. They have words like shallow breathing. Another way to say that is inadequate breathing, poor chest rise, labored, fatigued. That all points to respiratory failure or slow. So that's going to be respiratory rate less than 10 for sure. Now, respiratory rate greater than 30 may be respiratory failure. It also may be respiratory distress. So we can't always just look at the rate unless it's slow. If it's slow, less than 10, bingo, respiratory failure all day, every day. If it's greater than 30, I got to see if they got something else like shallow, inadequate, poor chest rise, labored, fatigued, stuff like that. If they have any of this, this is BVM territory. They're going to get a BVM, but we never do a BVM by itself. We have to power it up with oxygen. And if I'm at the point of needing a BVM, because the way you want to think of this is respiratory distress is they're struggling, but they can still do it. They can still fight. They're still in the fight with me. Respiratory failure is they're no longer in the fight. So now I got to fight for them. Make sense?
Mm-hmm.
If they can still fight, I'm just going to I'm going to support them with oxygen and say, look, let me give you some oxygen and you do what you can with this oxygen I'm going to give you. But when you quit fighting, I'm going to say, look, get out of the way. Let me fight for you. And I'm going to fight for you through my BVM. Okay? So the way you want to think is, can they do it on their own? Yes or no? If they can still do it, we're going to support them with oxygen. If they can't do it, I'm going to take over. Okay? Did that answer your question?
Yeah, because I just know in some of the test reviews and questions I've done, like that's
this is a huge topic. In fact,
Yeah.
let me see if this is inside. I don't know if this is where everybody has access to it or not. Let me see if it's under the free training videos section. I don't think it is. There is a part in the NRMT Pass Study course and let me show you what I'm talking about. In the NRMT Pass Study course and the 14 days program, there's this part here for, all right, here's what I'll do. Send me a message. There are two things I want you to look at. One is this OVP guide. The other is this handout or these right here. The video OVP, so oxygenation, ventilation, perfusion with drawings, and this OVP guide. These are, or this one, this respiratory failure. This would be a great thing to review today, because this is heavily tested on everybody's test. Like, you got to know the difference between respiratory failure and respiratory distress. Hang on one second. Okay.
Mm-hmm.
Send me a message and I can send you those links. All right. Anything else? Okay. Let's go to Winchell. This is your first day with us. We got a lot of new first people today. This is great. What was today like, my man?
It was very informative. I like going back and forth, doing the kind of one-on-one type of thing. I feel that I learned better with that. I like how you made everything click, everything connect. So.
Okay. So if you're not already in when is your test, by the way?
I just completed the paramedic coach. I did remedial training.
Okay, so you're on attempt number 4? Yes,
sir.
Okay. So, well, what was the difference? I'll ask the same question I asked Logan. What's the biggest difference you notice?
Kind of the same thing. Like, it was more PowerPoint based. When I started to get toward the end, it was kind of like, I gotta get through this class,
Okay.
this, that, and the third. But like I say, it wasn't like interactive. I noticed I learned better when I kind of talk about it with somebody, going back and forth. So. And
if you'll talk it and draw it, oh man, now you're a beast.
Yeah, so the drawing thing, and I'm just like, I don't know, let me try that,
Okay. Well, you see, that's what I'm constantly doing. Like, I'm constantly drawing pictures. But the reason I'm drawing pictures is the brain works in pictures. You ever had a dream?
Mm-hmm.
And how many of your dreams was it like PowerPoint slides flipping in your dreams?
I couldn't remember it.
Never. But you've never had dreams where it's like PowerPoints of your dreams, right?
Yeah.
No, it's never like, dreams. Okay, let me ask you, when you dream, are there words going across the screen of your mind? Like
no, it's nothing like that.
When you're dreaming in video and pictures. That's because the brain is working in video and pictures. That's why you want to have pictures for everything. If I can have a picture in my head for everything, I can instantly recall anything at any time of day, any day of the year, any decade, for years to come. Like, on the other hand, if you just learn by like PowerPoints or reading a book, you could like kind of know something today and not know it tomorrow, or not know it today. With pictures, though, it's like this stuff goes into a different area of your brain. It gets stored in long-term memory, and you're able to recall it for years to come.
Yeah, and something else. It was like the drawing and the colors. I guess you use different colors and stuff.
Okay. Yeah, especially when I'm talking about oxygenation, ventilation, perfusion, there's a consistent color coding that I do.
Hmm.
So here's what I'm going to say to you. I think Billy may have even responded. But if you're, I don't know if you're already officially in the program or not. If you are, great. If you're not, I would encourage you to get in at the pro level. Okay.
Okay.
Could you see why this would be beneficial?
Yes. But
Okay.
what's going on with the pro level?
Okay. So the pro level is, so we have 3 levels of access, and this is as of today. This structure is actually changing. Because what we found is the pro level is actually what gets more people results. And so we're phasing out the starter level. The pro level is the kind of middle tier level where it gets you all the bonus resources. So I'm going to go back to share my screen for a second. So when you sign up at the starter level, you just get these 2 programs, the NREMT Pass Study Course and the 14 Days program. Okay. This is the foundation that you need, because I'm going to teach you really how to pass the test. And that's what the focus is in this program, is how to pass the test. The 14 Days program is where I'm going to break down lots of questions, and we're going to do it together as a group, except they were previously live. Now you get all the replays. This NRMT Pass Study course is kind of the foundational stuff that a lot of people forgot, especially when they go from EMT to advanced or EMT to paramedic. They forget a lot of the basics. This is where I'm going to go over the basic foundation stuff that everybody needs to know. Okay. Everybody has to get these 2 in the program. So you get those. When you go to the pro level, in addition to these 2, you also get the bonus resources. The bonus resources has the Coach Joshua's 5-star drawing study guide. It's like 60 pages of just my drawings. So all these same pictures that I'm using, it's in one document. There's also the comprehensive study guide. So this is like, well, now it's probably 175 pages where I go topic by topic, page after page, and everything's in written form. And also some of the same pictures from the drawings one are also in the comprehensive study guide. So it's like everything in book. In fact, I have a meeting today. This will be a physical book very, very soon. This is actually, so I'm meeting with the rep today to talk about the whole Amazon piece. So this will be turning into the new physical book. There's a rapid drills. This is a big set of rapid drills where it's like 700 drills where I give you all the questions and then I turn around and give you the answers. But then what I also did is I sat here one day, I sat in the studio one day, and for 3 hours, I said every word of this rapid drill. So instead of reading it, you can actually have me in your ear, and you're going to hear question, answer, question, answer, question, answer. And I'm going to do all these quick rapid drills. So I'm going to drill you on opiate overdose, alcohol overdose, aspirin overdose, tricyclic antidepressant overdose, benzo overdose. Then I'm going to drill you on intubation. I'm going to drill you on, say it again.
No, I was agreeing. Yeah.
Okay. All right. So that's the rapid drills. That's the audio. There's also, you get access to a private coaching session where, I think this is Caleb. This is somebody who came through cohort 1. He was on his 5th attempt, a guy out of Oklahoma, Caleb. Had really struggled, had used like Paramedic Coach, Limmer, Pocket Prep, Medic Test, all the stuff most people use. He was still struggling. We ended up doing 2 private coaching sessions. Because at first I was like, Caleb, you're not ready. Don't you go and embarrass yourself. If you take this test today, it's not going to end well. Don't do it. He decided. He ended up doing private coaching with me. We did 2 sessions. He took his test like the next day, passed it, no problem. And you'll get a replay of that session. The other thing that you get at the pro level is for after you pass your test, you get the EKG Mastery Challenge. Like if you were to buy it separately, it's a $300 course by itself. But as a part of the pro level, it's just a bonus that we give you. And I'm literally going to break down every part of the EKG. Things like hemi blocks and bifascicular blocks and hypertrophy and axis deviation. You don't need this to pass the test. You need this to be a great medic. Okay? And that comes with the pro level. Now, for people who decide to do the accelerator level, They get all of this, but in addition to everything else, they also have 2 private sessions where I work with that student one-on-one for two sessions. And so that's where I'm able to, like, you and I just go through a whole lot of questions together, just the 2 of us with nobody else there. That's the accelerator level. So as of today, the pro level is $697 today. That's actually increasing. And the accelerator today is $1297. But those, I promise you, both of those are increasing. We've had a lot of demand. There's a whole lot of demand for this. So for most people, in your case, I probably recommend the pro level. But if for people who've already failed 5 times, for sure they need to be an accelerator. At your point, you're going into your 4th attempt. You could probably do fine with pro. As long as you're using it, as long as you're actually using the stuff. In addition to all of that, as a part of it, you're going to have access to, let's go here. You'll have access to the class marker account where you put in a group with, let's not show the people, let's show, okay. So you're put in a group with all the paramedic students, and you'll have access to 5 diagnostic exams. You also get access to 2 final exams, plus there are other subject-specific exams like acid-base disorders, EKG, Vaughan-Williams classification, endocrine emergencies, shock, things like that. And those exams are designed to help me help you get ready. Okay. So those are the different programs. Like I said, for most people, I recommend pro because of the bonuses. It's not only designed to help you pass the test, but you need to still be able to come back to it after you pass the test so that you can be great. Does that make sense?
Yes, sir.
Okay. So I recommend that you get in it. It doesn't matter to me if you get in it or not. If you get in it, great. We can help you even more. If you don't get in it, then you just have access to the free videos. Obviously, they're good. But you see how much is not included in the free videos.
Yeah, I like it going back and forth, and then you can look at my test and tell me what I did, and
Yeah. So what happens is I get, every time somebody does a test, any test, I get a notification, and then now I don't look at every single one of them in that moment, but especially as we're getting closer to preparing you for your test, then I will look at the scores. Okay, like prime example, Billy just tested last week. I looked at all of his exams. Monica is testing today. Monica and I have been in communication through last night. I was like, okay, these are the questions you missed. I sent her a guide of, hey, you missed these questions. I need you to review these topics tonight. That's the kind of support that we're providing you. But of course, we can't do that with people just at the free level because we just don't have enough time or resources to handle all of that. All right. Any questions?
No, sir. No,
okay.
Sir.
All right. We'll be back tomorrow. Here's what I say. Get in or don't get in, but just know that when you get in, you'll have a lot more support.
Okay.
Okay. And hopefully you found value in today. Would you agree?
Yeah. Definitely.
Okay. What was your biggest aha moment or takeaway today?
Definitely talking about the sales. Okay. That was just, what? Yeah,
Have you done this before?
No, I haven't done this before.
What was your school like? Like, what was the paramedic instruction like in your program? Was it online? Was it in person? What?
It was hybrid. So it was both.
Okay, so kind of a mix of the two. And how did the instructor teach?
I think she was pretty good. But mostly she kind of relied on slides. I did a lot of tutoring, so I stayed back, and she'll stay back and she'll, help out sometimes. But I think I needed a little bit more one-on-one, having like a conversation and going over things and why this works. For this class, yes, it was like
with your school.
Oh, we didn't have too many drawings, pictures,
Do you like that?
Yes. I just found out today, but I think the drawings pretty much help. So
okay. So Christian, you're in the program already. Tell Winchell, what's the 14-day experience like? Tell Jeff and Winchell. Christian, where you at? He left us. Logan, you're already in the
I'm
program,
here.
right?
Sorry,
Okay,
had to pee.
okay, Christian, tell the other gentleman, what is it like actually inside of our program? Because you're already there.
Yeah, it's awesome. I mean, my biggest thing that I love with this is compared to any other program that I've tried to buy or go through, is I really enjoy your flight plan or that plan to each day what you're supposed to do to complete it, and it kind of keeps me going. You know what I mean?
Focused.
Yeah, focused and
Okay.
and knowing what I need to do instead of just trying to guess and go through a whole program and just look everywhere to try and figure out, okay, what should I try and start with? Where should I start? All of those things very much gets cleared up within this.
What's been the biggest thing that you've noticed? What's been the biggest transformation since joining our 14 days program?
Since joining? Well, I feel like I've learned a lot more than I ever have. In my class, it was all PowerPoints, and they didn't dive deep into, like you said, there was that pyramid where the bottom level is where you don't want to be, and you want to be more toward the top.
The levels of learning?
Yeah, the levels of learning. I feel that, my levels of learning are increasing with this program, unlike any other program that I've ever tried to do, including my paramedic school, where they just teach you stuff, like you said, to memorize and not why it's doing it and how and what causes it and all of these things that put the pieces together that I never had.
And I think the biggest thing is when you understand the how and why, it's a lot, you have less to memorize.
Right.
Like, I don't have to memorize, like, what did I read on page 1238 in my book in the lower left corner that I highlighted 17 times in yellow.
Right.
I don't have to do any of that stuff. That's too stressful. When I really understand it, I have less to memorize. I can just recall at any moment through these pictures. I've got organized information in my head that I can just retrieve at any moment of any day, at any time of the day, any year, and I'll always kind of get to the right answer. Or I'll get to the right answer faster than most people. Or at least I may not always know what it's called or whatever, but I can figure out what to do about it. Okay.
Yeah.
And then, so Winchell, this is what I wanted to show you. This is just a highlight of, these are just people just in the last few months. This is not all the people. This is just people that kind of fit on like a page. But if you go through this and from the school thing, you can click, there's a thing in the upper right corner, student testimonials. But so for instance, oh, this is Caleb. This is the guy that was in the private coaching. He was on his 5th attempt. Jose here, he decided to take one session with us and take his test the next day. I was like, Jose, don't do this to yourself. He went on and failed the exam. Then he's like, all right, coach, I'm gonna listen to you now. He jumped back in. He came back in cohort 2, and you've probably seen him. For those of you who've watched the videos, you've seen all these people, most of them. Lucian was in cohort 1. I think he was on his 4th attempt. Because he did remediation and then joined us, and he was on his 4th attempt. Jonah Bell was on her 5th attempt. Filipino lady from Texas, had paid like $2,000 in all these other apps and programs. She's very skeptical. We talked for like an hour one day. Finally, she decided to jump in. She came in cohort, I think the end of cohort 1 or the beginning of cohort 2. Anyway, 2 weeks later, she went on and passed her test on her 5th attempt. I was the one that actually got to announce to her the day she passed. So she sent me a message. I called her. She was driving from the testing center, had about an hour to go. And I was like, hey, so literally as I was on the phone with her, the information changed on the registry website. I was like, hey, Jonah Bell, I want you to pull your car over. Can you just pull your car over? I want to talk to you about something. And she ended up pulling over. And I was like, well, I just want to be the first to say, congratulations, Miss Paramedic. And she wasn't paying me any attention. She just kept talking over me. I was like, no, Jonah Bell, like, you've passed. Congratulations. She's like, oh, no, coach. Oh, no, this test was hard. I'm like, no, Jonah Bell, listen to me. You have now passed your test. You are officially a paramedic. I was like, go check your email. And she checked her email while I was on the phone with her. And she's like, oh, my God, coach. Oh, my God. But like literally in real time, I got to announce to her that she passed. And so one of the things that happens is every single person who passes, you get a call from me. I personally call every single person. So we have a team, but I personally like to do those calls myself. And right now, like we've got 200 people in the community. So there will come a time pretty soon where I won't be able to keep up with these calls. But right now I call every single person. Jessica passed on her 3rd attempt. Mason passed on his 2nd. Abby, I think she was on her 4th or 5th. She also did private coaching with us. Kevin here passed on his 6th attempt with us. Katie, I think she was on her 4th. DeMarcus actually was one of the superstars, passed on his 1st attempt right out of the gate. He started with us, which was amazing. And so he didn't have all these failures like a lot of people end up with. He actually passed on his 1st attempt. But these, like if you'll go through these testimonials, it's a lot of them. And like there was a question one day in a Facebook group. Somebody said something like, somebody posted something in Facebook one day. Let me find it. Oh, this one right here. Somebody just put in, and you know, it's always these anonymous people. Lovely Dragon 4775 says, how many people have passed the NRMTP using the tutor named Joshua Crawford? And all these people, Christina's like, I did. Sherry's like, not only is his program good and will prepare you, he's an excellent clinician. She goes on to say, I had the opportunity to fly with him when he was working full-time as a flight paramedic. But this is just a list of people who responded to that post. And as you go through these, you're going to see all these people who've passed using the program. People have passed on their 1st attempt, 2nd, 3rd, 4th, 5th, and 6th. And this is only a small snapshot. I was literally looking at YouTube comments last night, and there was a whole list of people I've never even met. They only found us on YouTube, and now they watched a lot of videos. The problem with the YouTube is it just takes so long. You got to go through so much. So it takes generally more than the 3 weeks. I mean, those people have been watching me for months, but they pass. So what I'm saying is we've helped a lot of people. We can help you as well. But anything else, guys? We're way over time. I'm just having fun. Does anybody have any question? Anybody else? Jeff, I want you, your test is tomorrow. I want you to follow the 5-star medic method. Remember, if you can get everything down to oxygenation, ventilation, perfusion. As you're going through the questions, you want to constantly say, what is the safest thing I can do? Don't try to be the hero. You're testing for paramedic?
Yeah.
Okay. Everything is not intubation. In fact, what saves more lives is a BVM. BVM is always more advantageous than an ET tube. However, yes, there are times when somebody needs an ET tube. If you have somebody who's unstable, so point number 3 of the 5-star medic method is stable or not stable. We need to figure that out quickly, because if I have stable symptomatic tachycardia versus unstable symptomatic tachycardia, I need to treat it differently.
Mm-hmm.
If they're stable, I'm going to go with things like a vagal maneuver. Then I'll go with my 1st dose of adenosine, then my 2nd dose of adenosine. If they're unstable, I'm going to skip all that and go straight to synchronized cardioversion. If I can sedate them first, that's good. If I can't, I'm going to have to just go straight to it. But we're constantly saying, what's the safest thing I can do to prevent this patient from dying? And you're just going to keep asking yourself over and over and over, is this primary problem oxygenation, ventilation, or perfusion? If it's oxygenation, there are 2 things I do. I do something with the airway, or I give them oxygen. If it's a ventilation problem, that's either respiratory failure, respiratory arrest. I do BVM plus O2 plus airway adjunct. If it's a perfusion problem, I use my perfusion equation. Blood pressure equals heart rate times stroke volume times systemic vascular resistance. And I fix one of those to fix perfusion. Does that make sense?
Yeah.
So I wish you all the best, my man. Keep in touch with me. Let me know how everything goes tomorrow.
Yes, sir.
Okay. And are you okay if we pray?
Yeah, absolutely.
Okay. So, Father, we just come to you right now as humbly as I know how. We lift up Jeff. We lift up all the students who are testing. Father, we know that what you're able to do exceedingly abundantly above all we could ask or think. And Father, I just give you praise right now. I give you honor. I give you glory for Jeff as he goes on and tests tomorrow. For anybody else who I may know or don't know who's testing, for Monica, who's testing today. She's probably testing right this moment. I ask that you calm her mind. For everybody, for Jeff, I ask that you just calm his mind, bring everything back to his memory, allow him to be able to pass. We'll be sure to give you the praise, the honor, and the glory. It's in Jesus' name we pray. Amen.
Amen.
All right. All right. So I wish you well, my man.
I'll be in touch for sure. I appreciate you.
Okay. Yeah, no problem. No problem. All right. Anybody got anything else? I'm ready to go. I got to eat. I've had no breakfast, no lunch.
Joshua, I had one thing. I know I don't get any more questions, but it's a quick one. Tomorrow in
you done, man. That's it for you. Yeah, what you got?
I'm looking at the calendar, and tomorrow and Wednesday as well is 2 more live sessions. What's the difference between tomorrow and Wednesday?
Tomorrow is Wednesday.
Oh.
But tomorrow and Thursday?
Tomorrow and Thursday, sorry.
Okay, so the purpose of the Tuesday morning and Thursday evening is just for us to do, like, if you have questions, kind of like what we did today. I don't necessarily have a topic plan unless it's one of the days where I do.
Okay.
Like today, I didn't know what we were going to talk about. I just came on ready to answer your questions, and we went a whole lot of ways quickly. That's Tuesday and Thursday. Wednesday is just the weekly accountability meeting for you to just come on and say, all right, this is your game plan for the week. Do you have any questions? Are you stuck on anything in terms of like, what resources do I use? Stuff like that. It's not so much supposed to be about questions, but obviously it's different every time in terms of what questions people have. And I'm just prepared to answer questions, whatever they are.
Copy.
Okay. So, I mean, you don't have to attend everything, but you definitely want to show up every week to something, whether it's the office hours on Tuesdays or Thursdays or the weekly accountability meeting on Wednesday. You want to show up to something. And the more you show up, like today, you asked some questions that I was able to answer that I wouldn't have answered otherwise, right? Or, I mean, you may have messaged me in school, but I can't really draw all this stuff when I'm just responding to you in school in a message.
Right.
Okay. Does that answer your question?
Yes, sir.
Okay. All right. Keep going, my man.
Thanks.
All right. Anything else, guys? Jeff, you good? Logan, you good?
Yes, sir. Thank you.
How soon you going to be done with your remediation?
Well, I'm going to work on it today, probably till around 4 or 5 o'clock, which I'm on the Eastern Shore. So I'll work on that. I finished airway yesterday, so I'm actually moving into the cardiology stuff and all that stuff. So I'm hoping to get it done.
All PowerPoint essentially?
I mean, Paramedic, it's like he goes through a PowerPoint, but he's also like there in the video kind of explaining things, but he's not doing any drawings or anything like that. I mean, he has some diagrams here and there, but it's mostly like, it's also like if you have a question about something and you're going through a video like that, it's kind of hard to ask a video a question.
Yeah, there's nobody to talk to, right?
Right.
Yeah.
So
I think, like, to my knowledge, I don't actually know of a single program that does the live interaction that I do.
Right. Yeah.
To my knowledge, I don't know of anyone that exists.
Aside from going on like one of the tutoring websites and paying somebody $85 an hour, but
okay. And so what I would say is, people right now who could probably benefit from our program. Like, don't wait until you've passed. If you've gotten value already, share it with other people.
Absolutely.
There are people probably on your job or people you went to school with who need help. Like, let them know. Or also, if you see people posting on Facebook or any of the social platforms, TikTok or anywhere, wherever you are, if you see people saying like, hey, I failed and I need help, don't hesitate to let them know, hey, reach out to Coach Joshua at Level Up Medic, and you can tell them about your own experience and how it's helped you.
Yep.
It's interesting you say that. My buddy in the paramedic program I did.
I forgot you were still there. Say that again.
The buddy in my paramedic class didn't pass his national now. I think it was 3 times. And then he's in his remedial. And I told him, dude, I sent him the video that led me to you anyways from YouTube that I told you about. And I said, this is where you need to get into to help you pass. And he's all about it. Watched your videos. And I think he's going to be purchasing it here soon.
Okay. Well, remind him, like, call him and say, hey, you need to get in this program, man.
Yeah.
Okay. All right, guys. Anything else?
Hey, Josh,
Joshua,
one quick question.
Sure.
I I was looking over the last little tidbits as far as like the brain dump, but you had an acronym SEUD, correct?
SEAD, seed.
AD.
Okay, our seed
That's right.
tricks.
The seed trick. Yep. I was trying to describe this one to my medic yesterday, and I just didn't have the paper in front, but
That's okay. These are wrong answers. All right, so when you look at your, let's say, whether it's multiple choice, drag and drop, whatever, S stands for scope. If it's outside of your scope, it's wrong. And what I mean by that is you're testing for paramedic. So on the test, you're only a paramedic on an ambulance. You're not a fire medic. You're not a hazmat trained person. You're not a diver. You don't do special operations, nothing. You're paramedic. So nothing outside of your scope. You don't do anything that jumps to expensive stuff too quickly. Okay. Most of the time that's some kind of medication. Now, there are times where you need a medication, but often there's something simple that we do even before medications, unless it's an unstable patient. And then, well, even in that situation, no, I'm sorry. No, with medication, the one exception is anaphylaxis, epi. Like we do it kind of first.
yeah.
But otherwise, like if they're unstable, we're going to typically go, some people say Edison before the medicine, but electricity before medications in unstable problems. A is for advanced, anything that's too advanced too quickly, or you skipped basic stuff. Like going straight to an ET tube and you haven't ventilated is probably too advanced too quickly. And then D is anything that's going to delay care. Okay, because our goal is to give safe care quickly. So anything that's outside of your scope, anything that's too expensive, anything that's too advanced, or anything that's going to delay care, those are probably wrong answers. So sometimes, even if I don't know the right answer, if I can just eliminate the wrong answer, I'm only left with the right answer. So let's say they give me 5 things and I got to pick 2 out of the 5, just eliminate 3 that are wrong. Now, why would they be wrong? Well, they're one of the seed tricks. Those are wrong. Why else would they be wrong? A big thing
OVP.
that makes things wrong is they fix the wrong problem. You said this situation is an oxygenation, or let's say you say this is a ventilation problem. Well, if it only talks about giving oxygen, just giving oxygen does not fix a ventilation problem. That's why that answer is wrong. It fixes the wrong problem. Okay. Yeah. This is like magic.
Yeah.
Okay. Anything else?
No, that's it. Because that kind of helps. It's like a last ditch effort as far as like going through the patient assessment and then the different triangles. And then if you can decipher it, go last to first. Most likely it may not be A, and just use that kind of process of elimination.
The other thing you want to know is the 5 triangles. Okay. You have oxygenation, ventilation, perfusion. That's our main one. You have the trauma triad of death. You have Beck's triad, Cushing's triad, and then the pediatric assessment triangle. Okay. And you want to know those. You also want to know Mr. Ladd. You know Mr. Ladd?
Yep.
Okay. You want to know Mr. Ladd because that's going to help you answer your 12 lead questions. So we've got 4 inside the t-shirt. We've got 4 outside the t-shirt. We chop them in half. And then we've got 2, 3 AVF down here.
And now with the other 3 leads for the 15 lead, would that be considered for your posterior?
Yes.
Okay. Because somebody the other day got a question about that. So I know they're maybe dabbling that back in.
Okay. But even if you only have the 12 lead, so you only have 10 wires, so 10 electrodes that make up the 12 lead. Even if you don't have it, then what you want to know is like where would you have reciprocal changes? And what that means is if you have ST elevation in one place, you have ST depression on the opposite side. Okay. So for instance, since these leads are on the anterior part of, they're looking at the anterior wall of the heart. if I have elevation in the anterior side, I'm probably going to have depression in the posterior side.
Mm-hmm.
Okay. Or if I have ST depression here, I'm probably going to have ST elevation in the back. So even if I don't have enough electrodes to put stickers on the back, the fact that I have ST depression here likely indicates that I have ST elevation in the posterior leads.
Gotcha.
That's just something to know. Okay, my lateral leads over here on the side of the t-shirt, this is going to be 1 AVL V5 V6. Let's just label those. That's 1 AVL V5 V6. These are my lateral leads dealing with the circumflex artery. Down here, 2, 3 AVF. These are below the line, so they're inferior to the line. These are my inferior leads dealing with the right coronary artery for 85% of the population. For the other 15% of the population, the bottom of the heart receives blood through the left anterior descending artery. And then the ones inside the t-shirt, the 4 there are going to be V1, V2, V3, V4. Okay, V1 and V2 are my septal leads that are just across the ventricular septum. And then V3, V4 are my anterior leads that are looking at the front of the heart, but I could just call all of this anterior if I want to. Okay, so that's Mr. Ladd and your 5 triangles to include OVP. That's helped a lot of people. Okay. And literally, Jeff, this is something we covered day 1, session 1 of the.
Oh, trust me, I have all the drawings too. I've been in it, doing it, deciphering it, and it's been helpful for sure.
Good.
So, yeah.
All right, guys. Well, that's it for today. This was a long session. All right. Anything else?
Yes, sir.
No, sir. I appreciate you.
No problem. Well, you guys have an amazing day. I'll see you guys tomorrow if you show up.
Thank you.
Okay, and Jeff, good luck.
Appreciate you. Check.
All right, bye, everybody.